Buongiorno prof, possiamo procedere con la diretta.
Okay, good morning to everyone. Good afternoon to everyone. I think that it's time to start. Good afternoon to everyone and welcome, very welcome to this the final exam of thesis. This is the graduation day of the international degree course in medicine and surgery. Let me introduce myself very briefly. My name is Paolo Villari. I am professor of hygiene in this university, and I'm also the president of the degree course in medicine and surgery. Microphone. Okay, let me introduce myself. My name is Paolo Villari, and I am professor of hygiene in this university, and I'm also the president of the degree course in medicine and surgery. The dean of the faculty of pharmacy and medicine, the Professor Carlo Della Rocca, asked me to replace him in the presidency, in the chairman in chairing this committee, and I'm very glad to do that. First of all, I would like to make a special thank to all professors of this committee. Thank you very much for coming. This is, I think, that you candidates are very lucky because you candidates today you have the opportunity to discuss your thesis and the results of your work in front of this professor, and I'm quite sure that there will be a very useful and interesting discussion. This day is the day of the final exam of the thesis. And I think that this is a sort of a special day for you candidates because it is the conclusion of a long pathway during which you spent a lot of time and energies in order to prepare the exams, to follow the lectures, and also to prepare your final work of the thesis. Let me say that the graduation day is a sort of ceremony, and there's a ceremony that deserves a sort of appropriate atmosphere. We have a sort of behavioral code to respect. There are some words, some Italian words that are very difficult to translate in English. One of these words is sobriety, moderation. So I think that it is important that we maintain this atmosphere, special atmosphere, in this class, in this room, but also outside the room, outside the building, and also outside the university. Again, you are very lucky, you candidates, because today we are coming back to the traditional environment in presence after the lockdown due to the COVID-19 emergency. We have to follow all the safety measures, but we are very happy to do that. And I do hope that you transmit this behavior also outside the Sapienza community, to your family, to your friends, because it is very important to maintain in these measures. This is a duty of physicians graduated by the Sapienza. In conclusion, this is an important moment of your life because you are becoming the physicians qualified to exercise immediately the profession after this ceremony, with some exception, without the need of the state examination. You candidates are likely to be reminded and recorded as graduates at the time of COVID-19 emergency. This month have been very difficult for all of us, for we, the professors, and also for you students. But I'm sure that this experience have fortified ourselves, and we will be fortified by this experience. You have to be proud about this situation, but particularly you have to be proud about the fact that you will be the graduates of the International Medical School of Sapienza University of Rome. Okay, after this brief introduction, I think that it's time for the first candidate. The first candidate is Francesco De Certo. Please, Francesco. Francesco De Certo is presenting the thesis whose title is Pathophysiological Mechanism of Fatigue in Multiple Sclerosis. The supervisor of the thesis is the Professor Alfredo De Berardelli. Please, Professor De Berardelli, introduce briefly the thesis and the candidate. Please, Alfredo.
Thank you. In neurology, usually when a patient has weakness, we think that he has an affection of a parameter system. But it's actually not the case, because there are many cases, many patients that complain of muscle weakness without any specific lesions in the central nervous system and in the peripheral nervous system. The candidate has
And second of all, try to correlate on multiple sclerosis. The way we used to treat patients was by asking them to repeat muscular contraction of the level of the extreme verse, you can see in the video. So this was repeated several times until the patient couldn't keep up anymore with a certain intensity of contraction. At the same time, during the contraction, patient received the peripheral stimulus at the level of the peripheral, as you can see in the picture. And the resultant surface electromyography was reported, showing how the patient basically received a series when it was at the maximum intensity of contraction, and another one at the rest state, giving rise to two potentials. One that is known as the contraction pitch, and the other one is the rest pitch. So the peripheral fatigue was based on the output of the rest pitch. Thus, it develops, as the peripheral fatigue develops, the twitch gets smaller and smaller. While central fatigue develops, the contraction pitch ability will get larger, because the central nervous system is not able to recruit maximum units. Why, regarding cortical correlates, we use the TMS for potential. TMS, which is transcribing magnetic stimulation, consists in a local magnetic stimulus acting at the level of the motor cortex that generates potentials in underlying neurons. These potentials are then recorded, they are analyzed, and they are analyzed both locally, so both where we have the stimulus in the TMS, and also globally, so the global network associated anatomic area that was stimulated. To get the local nuclear amplitude, that is a cortical correlate of local stability, and the global one, that is a cortical correlate of global stability. We measure the TMS of the head, also known as STEM, in the pregnancy, so we perform the neurological assessment, and in the post-fatigue, so after the patient reaches fatigue and couldn't keep any more resistant function. Results came out from our groups of 10 patients and 10 healthy controls were, first of all, the most resistant index, there is an index of all resistance, means that the ability to carry on with the contractions, the blocks, and the intensity, the contraction was higher in the so in general, healthy people have more resistance and stronger than patients. Regarding peripheral, we could apply a major difference between the two groups. What was significant was that the total group increased from the beginning of the task to task failure corresponding to the core block. So it means that peripheral contributed equally in both groups in developing task failure. What was nice on the other end was central fatigue. Central fatigue, that corresponded to the progressive increase in the contraction pitch, was more or less stable in the other controls, while you can see that the patients red, it increased steeply until task failure. And after task failure, there was a significant difference between the two groups. So that means that the central origin of the indications were more important to determine task failure in the task compared to the other controls. Regarding the cortical correlate, on the other hand, we didn't find any significance in terms of the local nuclear amplitude, so the local excitability, even though we can see a trend that was decreasing the excitability in healthy patients in brain post-fatigue. In white patients with multiple sclerosis, it was more or less the same. So we believe that probably by using the numbers of enrolled people, this could turn out to be significant. Why? Regarding the global median amplitude, so the global stability at the level of the cortex and the network state to the motor task, it was increasing. So that means that the patients didn't modulate as healthy control speed. It was more or less stable, while healthy controls, the global median amplitude progressively decreased post-fatigue. So once the patient developed the motor. Therefore, our conclusions are that the most fatigue in multiple sclerosis is mostly the result of a failure by the central nervous system to recruit classifiers. The development of amplitude reduction is possibly a cortical correlate of motor fatigue in healthy controls, while it doesn't change in patients with multiple sclerosis. And then usually the failure motivated the non-cognitive amplitude and the global one patients could reveal some pathophysiological background of sensitivity in patients with multiple sclerosis. And potentially this is to be a starting point to find a neurophysiological biomarker to evaluate, to measure fatigue that until today is only assessed by clinical scale. So it is a little bit biased by the self-perception of the patient. Well, this will be more effective than positive. Thank you.
Thank you very much, Francesco. I have to ask if there are questions by professor of the commission, the committee. There are any questions for Francesco? Professor Berardelli, as a supervisor, do you want to add a comment?
I think that this is a very interesting result, and it can be certainly used for also the evaluation of treatment that we do in these patients with immunotherapy. So possibly this can open a new way to look at the effect. Central fatigue is a symptom that many patients with multiple sclerosis complain, and is a very important symptom. So I think it's a very nice study with insight into the mechanism of why these patients have fatigue.
Okay.
So I like to congratulate you.
So I have to ask you formally if you are satisfied about the work of the candidate. Are you satisfied?
This is either yes or no. Yes.
Thank you. Thank you very much, the Professor Berardelli. Thank you very much, the Francesco Certo. And congratulations for your presentation. Thank you. Bye. So it's the time of next the candidate. The next the candidate is the Azal Okzan. Okay, the Ozcan Azal the Ozcan is presenting the thesis. The title is comparative effectiveness of rate control therapy for atrial defibrillation in patients with the sepsis. The systematic review and meta-analysis. The supervisor of Azal is the professor Roberto Cangemi. That they will introduce briefly the candidate and the thesis. Please.
Different projects, and in the end, because of the topic, we have a choice. And until we started in the past, other prevention, in some conditions, like pneumonia, we decided to perform a meta-analysis to study how other prevention, like the common to failure sepsis, is treated and how should be treated. This is another problem.
I would like to thank Prof. Cangemi for his kind introduction, and also I'm very delighted to be here, and I would like to thank our committee and our guests for being here.
Try to speak as louder as possible, okay?
So I need to talk about the systematic review and meta-analysis that we've done about the comparative effectiveness of rate control therapy for atrial fibrillation in patients with sepsis. So over the past 6 years, as a medical student, I've seen my share of patients with atrial fibrillation. We know that it is extremely common, and it is the reason why it's important is because the population associated with mobility and poverty, in which case the mechanism is while the population is skyrocketing, it's due to risk factors such as sepsis and also the aging population. Sepsis plays a role in the triggering atrial fibrillation in terms of the systemic formation, circulating stress hormone, as well as hormone dysfunction and the promotion of protein factors stay in the body. And which is atrial fibrillation is why it's massive. There's because when
Something that's really prevalent, such as sepsis,
as well
associated with poor outcomes. So this is just to see that, just to show you that existing guidelines for the usual atrial fibrillation patients are very clear, and we know what we need to do. We act depending on if the patient is hemodynamically stable or not, and then we start the rate control therapy. However, in the setting of atrial fibrillation patients with sepsis, the guidelines, there are no clear guidelines, and usually what we need to do appears to be very vague. So despite the significant impact of sepsis on the management of atrial fibrillation, looking at the guidelines, we can find a general lack of consideration about this clinical issue. So therefore, our objective, our goal with this systematic review is to evaluate which antiarrhythmic agent is associated with better outcomes in sepsis patients with atrial fibrillation. So this was our search strategy, in which case we used the PRISMA guidelines and recommendations in order to collect studies. We used some keywords such as atrial fibrillation and sepsis, and we used databases from PubMed and Embase, in which case, in total, we obtained 4,116 studies, and then we eliminated some studies, the duplicates, we eliminated them, and then we sort of analyzed their abstracts and titles, and then we were left with 68 studies, in which case we used some inclusion and exclusion criteria that we will see in a bit. And then in the end, we were left with only 2 studies, and we added 1 more study depending on the author's knowledge. And so we started our study with only 3 studies. So the study selection, as you said, we used some inclusion criteria, which involved, we included all the studies that reported patients with sepsis and atrial fibrillation, as well as all the studies that are reporting on antiarrhythmic drugs, but also reporting on the outcomes according to the antiarrhythmic drug that was used. We excluded all the studies that were conference abstracts, comments, editorials, case reports, and systematic reviews and meta-analysis. And we also didn't include the studies that didn't report outcomes according to the antiarrhythmic drug exposure. So this is a table that represents the characteristics of the studies that we included. So we only had 3 studies here. And looking at the sample sizes of the studies, we can see a huge disproportion in the sample size, as well as all the study designs, they were observational studies. So there were no randomized control trials at all in the database. And we took into account the severity of the illnesses of the patients as well by looking at their high SOFA scores. And in case the study didn't include the high SOFA score, we looked at their the percentage of patients that were on ventilation and were on vasopressors. So these were our results, in which case we did pooled estimates. So in panel A, we can see the comparison between beta blockers and calcium channel blockers. And looking at the heterogeneity, it's very high. The I2 is 71%. So as well as the heterogeneity in panel B, in the comparison between beta blockers and digoxin, the heterogeneity is very high. So when we looked at the total random effects, we saw no statistically significant difference between the use of the 2 drugs. However, when we applied the fixed effect model, we saw that beta blockers had a significantly significantly reduced risk of in-hospital mortality in patients with atrial fibrillation during sepsis. Also looking at the panel C, we saw that there was 0% of heterogeneity. So therefore the random effect model and the fixed effect model was equal to each other. And so beta blockers were statistically significant, significantly 48% better in reducing the in-hospital mortality. So our systematic review and meta-analysis showed that very few studies examined this clinical issue. However, beta blockers have a significant reduction in in-hospital mortality, around 50% compared to the amiodarone users, and also the possibility of beneficial effects of beta blockers over any other antiarrhythmic drugs, so digoxin and calcium channel blockers. However, we realized that there was some controversy between the three studies about the effectiveness and safety of the beta blockers. Basically because although beta blockers were very good initially about controlling the heart rate of the patient, later on we realized that in some studies it led to the requirement of additional treatment. So our systematic review shed light on some of the major significant aspects. So far, only experts have given indications suggesting the beta blockers effectiveness as first-line therapy. However, the meta-analysis substantiated the indication of beta blockers as first-line therapy. So we had several limitations during our study. There were no number of studies, and also there was no randomized control trials, and therefore this very highly reduced the generalizability of our results. And also we couldn't make comparisons between class 1C antiarrhythmics, mainly due to the fact that only one study included this antiarrhythmic drug. We were unable to compare outcomes between calcium channel blockers, amiodarone, and digoxin due to the design of the studies, which did not allow us to compare them. To conclude, in systematic review and meta-analysis, beta blockers were associated with a reduced risk of in-hospital mortality compared to all the other antiarrhythmic drugs. However, it appears clear from our previous mentions that the answers from larger randomized controlled trials are urgently needed in order to draw definitive conclusions and to inform the guidelines.
Thank you very much. Thank you very much, Zallo, and congratulations for your presentation. Are there not any questions by the professor of the committee? I have a question on that, I'm sorry. Okay, so I do agree about the fact that you trust in the fixed effect on the model in this case. So I think that there are in all three of the meta-analysis statistical significant differences. But I think that it was due to the fact that in the random effect model, that there is a very large heterogeneity, but the one study is very small. Okay, so I think that it's quite important to understand why the results of the small trials is so different from the results of the first trial. I think that this is the most important question that you have to address. What do you think about that? Yes. I mean, I think that you have to trust the fixed effect on the model in this case, because there is one trial, very small, results that are very different from the large trial. So my question is, what is your idea? Why the results of the very small trial is so different from the results of the large trial, in your idea, your opinion?
Yeah, probably because the larger study, the first one, we can see from the historical conditions that they have atrial fibrillation from before, and probably there was a higher heterogeneity between the medical history of the patients, and probably there were more patients
In the Walkie study.
so it could be related to that.
Okay, the Professor Cangemi.
can it is interest is that the problem is really open because most of the time we don't know absolutely what to do in the person with sepsis that has arrived to have a septic shock. In this case, we tend to use, for example, amiodarone because it's more safe than beta blockers in the context in which maybe the pressure can be low. So it's very important to do prospective study to understand if what we see here is just the fact that we give beta blockers to patients that are less skilled and amiodarone to patients that are more going to shock, or there is a real threat.
Professor Kangemi, I have to ask you if you are formally satisfied by the work of the candidate.
Absolutely.
Thank you very much. Thank you very much, Azzala. Congratulations. The next the candidate is Marco Pistone. Marco Pistone is presenting the thesis. The title is Mutational Analysis in Patients affected by B acute lymphoblastic leukemia without major molecular lesions. Biological correlation and potential therapeutic implication. The supervisor of the thesis is Professor Chiaretti, and the prisoner the Professor Chiaretti, and introduce briefly the candidate and the thesis. Thank you.
Disease with a very good prognosis. However, presently, both the introduction of very intensive treatment as well as the better definition of molecular aberration is changing the paradigm of this disease. In particular, Marco's thesis focused on trying to identify molecular aberration in the patients which are devoid of this until recently. So he will discuss his results on PD negative lymphoblastic leukemia without any major molecular aberration. So please, Marco.
Thank you, Professor, for the presentation. So I will start with a brief introduction to B acute lymphoblastic leukemia. So this is a disease that is characterized by. Okay. So this disease is characterized by the acute proliferation and accumulation of B-cell blasts, first at the level of the bone marrow and at later stages in other extramedullary sites. It presents with a bimodal distribution of incidence. The first peak is in childhood, when it is also the most frequent malignancy of all. And then there is a second peak in adulthood above the age of 60. The prognosis of the patients also changes dramatically depending on the age of presentation. In fact, while children have an overall survival that exceeds 80%, adults above 65 have an overall survival that is less than 15%. After having confirmed the diagnosis, it is important to perform cytogenetic and molecular biology techniques in order to provide the best possible therapy for each patient. The therapy itself can be divided into chemotherapy, novel targeted therapies, with or without the use of allogeneic transplants in high-risk patients. So the risk stratification of the lymphoblastic leukemia is complex and takes into consideration a number of risk factors. This can be divided into patients-related, disease-related, and those related to therapy response. And the genetics of the disease are becoming more and more important. In fact, while until recently, a diagnosis would only check for the presence of Philadelphia chromosome, MLL1 translocations, and IGHV translocation. Nowadays, we know many other molecular aberrations that have an impact on both prognosis and therapy response. So the aims of our study was, first of all, to evaluate the incidence of new subtypes of EALL and to check for the presence of concomitant molecular aberrations. Secondly, to correlate these subtypes with with biological findings, mainly minimal residual disease and patient's outcome. Third, to understand the role of rare molecular aberrations on treatment response, with the hope in the future to implement the use of genetic-driven targeted therapies to new BLL subtypes. And finally, to overall improve the risk stratifications in patients affected by beta-lymphoblastic leukemia. So we studied 146 patients that were taken from the nationwide GMEMA LAL 2317 phase 2 clinical trial. These patients all were affected by Philadelphia negative acute lymphoblastic leukemia, and they were treated with an intensive chemotherapy that is MRD driven and pediatric inspired, together with 2 cycles of blinatumomab. This is a monoclonal antibody that is specific, and it targets both CD3 and CD19, allowing the T cells to undergo cytotoxic reactions against the malignant B cells. So the enrolled patients underwent a comprehensive molecular screening that included, first of all, the assessment of pH-like status that was done by our in-house built algorithm that was uploaded online onto a platform called REDCA, and this assesses the expression of 10 different transcripts. Secondly, we performed RNA targeted sequencing for the study of human genes. This was done by an Illumina 2-site RNA consensus panel that checks for 1,385 different types of genes. Third, we performed DNA targeted sequencing by NGS to check for the presence of mutations in 36 different JAK-STAT and RAS-3 genes. And finally, we performed multiplexation dependent quantification for detection of copy number aberrations and in particular deletions. After each cycle of chemotherapy and each cycle of blinatumomab, we performed minimal residual disease analysis that was done by quantitative PCR. So the patients studied had a median age of 41 years. There was a slight predominance of males over females, and it is important to note that 18% of the patients studied had an age at diagnosis that was above 65 years. We were able to reclassify 42% of the patients studied into new subtypes, the largest of which was Philadelphia-like acute lymphoblastic leukemia. This is an already widely studied type of Philadelphia negative acute lymphoblastic leukemia that shares similarities with Philadelphia positive lymphoblastic leukemia concerning the biology and the genetic expression profile. So in this population, there was 25% of the patients studied. We identified a statistically significant higher number in mutations affecting the JAK-STAT pathway genes, an increased number of deletions in PAX5, IPEROS1, and EBF1, together with a slight increase in the number of fusion genes. In particular, we found 4 patients with ABL class fusion genes and 5 with PCR JAK2 fusion genes. There was also a slightly smaller number compared to pH-like, non-pH-like lymphoblastic leukemia patients in mutations affecting the RAS pathway genes. So the overall outcome of these patients was poorer compared to non-pH-like patients. In fact, we saw at 12 months a disease-free survival that was 57 compared to 86%, and an increased cumulative incidence of relapse of 44 compared to just 9% in pH-like ALL patients. Both of these data were statistically significant. The second largest subgroup identified was patients with ZNS384 arrangements. These were 9% of the patients studied. We identified the partner gene in each of these cases, and we found that the most common partner genes was EP300. Also, we analyzed the concomitant molecular aberrations, and in particular, we found deletions in CDKN2A and 2B in 3 cases, in ETV6 in 2 cases, in RB1 and IPEROS1 in 1 case. The outcome of these patients was slightly better compared to that of non-rearranged patients. And even though this value is not reached statistical significance due to the small number of patients studied, we saw that thanks to the implementation of the combined immunochemotherapy, the disease-free survival at 12 months in these patients was 100%, compared to just 78% in non-rearranged cases. The third largest subgroup was patients presenting with methylation rearrangements. These were 4% of the patients studied. They all had deletions in CDKN2A, and they had poor outcome. In fact, while all of them underwent complete molecular remission, complete hematologic remission at time point 2, 3 out of 4 had the presence of minimal residual disease, and eventually all of them relapsed, with 2 patients diseased at the time of the last survival analysis. Finally, we found 4 other rearrangements, 2 in PAX5 and 2 in IPEROS2. So in conclusion, we were able to reclassify 42% of BNEC ALL patients into new subtypes. We found the molecular aberrations present in each of these subtypes, the largest of which was patients with PH-like lymphoblastic leukemia. This was 25% of the patients studied, and they showed a poorer outcome compared to non-PH-like cases, despite the implementation, unfortunately, despite the implementation of a combination of immunotherapy and chemotherapy. The second largest subgroup was patients with ZNF3 arrangements. These were 9% of the population studied. And again, it is important to stress that they had a disease-free survival at 12 months of 100%. The third largest subgroup was patients with MEF3 arrangements. These were 4% of the patients studied. Again, they all had CDKN2A deletions, and also they presented with poor outcome despite the combination of the immunotherapy. So all of this goes to show that there is still, in fact, the need for the implementation of appropriate genetic-driven targeted therapies, especially in subgroups, namely the PH-like ALL and patients with MEF3 arrangements, while there is the potential for to provide milder therapy regimens in patients with lower risk molecular aberrations, such as ZNF3 arrangements. It is finally important to point out that all of this data gathered will in fact be valuable for making a more detailed and useful classification for the stratification for the risk of the acute lymphoblastic leukemia patients. Thank you.
Thank you very much, Marco. Thank you very much for your presentation. Are there any questions by professors of the committee? I have a question for you, Marco. I mean, I understood quite well that between the three subgroups that you have identified, there are important differences in terms of prognosis. But which are the clinical implications? I mean, you mentioned at the end the possibility of targeted therapy. Could you say something more about this aspect?
So essentially, nowadays, we are able to change treatment only in patients with major molecular lesions. In fact, the majority of ALL patients are PNEC patients, so without these molecular lesions. And these are all considered standard risk. In fact, we're seeing that these patients, depending on how the molecular lesions present, for example, PH-like lymphoblastic and MEF3 arrangements, they have a worse prognosis compared to the other patients without major molecular lesions. But unfortunately, nowadays there is still no standardized therapy treatment for these high-risk subgroups that will allow us to bring the prognosis to a comparable level to that of non-range or PH-like patients. So it is still something that we are hoping to see in the future with the implementation of genetic targeted therapies. But nowadays, there are still, well, there have been some studies with targeted kinase inhibitors for PH-like patients, and also some studies in vitro for example, MEF3 patients and some ZNF3 followers. But unfortunately, there is still no shared standardized therapy for these subtypes.
Okay. Thank you, Marco. The Professor Chiaretti, are you satisfied about the work of the candidate?
Satisfied. Just to precise that, in fact, for the PH-like ALL, there is a lot of effort.
Speak at the microphone, please.
There is a lot of effort ongoing, mostly for the PH-like ALL, to try to change completely the treatment and the ALL. So we are trying to fight against the pharmaceuticals.
Okay.
I'm satisfied.
Okay. Thank you very much. Thank you very much, Madam Marco. And congratulations. Congratulations to Marco Pistone. And now it is the time for the next candidate. The next candidate is Anna Maria de Manta. The title of the thesis of Anna Maria de Manta is the winding the potential of military small arms, analysis of the dimensions of entrance and exit wounds, and comparison with the conventional handguns. The supervisor of the thesis is Professor Costantino De Ciallella. Please, the Professor De Ciallella, if you introduce briefly the candidates and the thesis. Thank you.
has developed an experimental thesis about the chapter of forensic pathology as gunshot wounds. She studied the dimensional relationships between entry and exit wounds of military small arms compared with conventional handguns. A topic with few published experience, since these weapons are used in war conflicts. It is a multicentric study carried out with Bangkok and Chicago. So,
can you hear me? Can I just take it out? No? Can you hear me now? Perfect. So thank you, Professor Cialella, for the introduction. As you briefly mentioned, our analysis was directed towards the quantification of the damage caused by military small arms. And for a DSA, okay, no. Okay. Grazie. So for the sake of our analysis, we can broadly classify small arms into those designed for military purposes and conventional handguns, such as semi-automatic pistols and revolvers. In the tables, you can see summarized the characteristics of the small arms, the military ones that we encountered during an analysis. So we have the AK-47 and the M16, which are the two most common assault rifles used especially in a military context, while the FNAB-43 and the Scorpion 61 are two submachine guns that use the same type of ammunition as conventional handguns with different operating mechanisms. So the intrinsic wounding capacity of the bullet is given by the mass, the velocity, the caliber, the shape, the construction, and the material. But we can oversimplify it using the kinetic energy, which is the bullet's resultant of the motion and mass, and where the velocity has the highest impact on the final velocity and energy of the bullet. So the definition of high velocity bullet has changed throughout the decades. The value to exceed was considered to be 330 meters per second originally, so the speed of sound in air. But nowadays, due to changes in the construction of the military small arms, the value to exceed is 600 meters per second as muzzle velocity. So the main difference between the low velocity bullets and the high velocity bullets is the temporary cavity effect, which is caused by the radial acceleration of the bullet that produces displacement also to surrounding tissues. As we can see in the images that were obtained by Faulkner in 1996, the temporary cavity and the permanent cavity for low velocity bullets are nearly superimposable due to the uniform energy transfer during the bullet track. While when it comes to high velocity bullets, the temporary cavity, the energy dissipation that is non-uniform along the bullet track, we have the formation of the permanent cavity that is greater than of the temporary cavity that is greater than the permanent cavity. So in this case, we can see how the damage can occur both at the site, is extensive, both at the site of the permanent track and at the temporary cavity. So the typical entrance wounds are characterized by a round shape that are surrounded by abrasion collar and contusion ring, so with areas of hyperemia, hemorrhage, and micro tears, skin tears especially, while exit wounds tend to be more irregular in shape and are characterized by the absence of this contusion ring abrasion collar complex that makes it easier to discriminate between the two types of lesions. When it comes to military small arms, we have, the damage can be even more extensive when it comes to exit wounds with leakage of soft tissue material. So the fact that the exit wounds in military small arms are greater and more extensive compared to conventional handguns has never been quantified and measured. So we decided to collect medical legal reports from our department, were mostly concerning terrorist attacks and military casualties during missions abroad. And we decided also to include 2 other facilities in our analysis, including Maydol University, which provided reports from a 2011 mass rally where M16 assault rifles were used, and the Cook County Medical Examiner Office of Chicago provided the entirety of the control group, meaning with conventional handguns. We included only perforating gunshot wounds, so wounds with an entrance and an exit wounds, while excluding all the lesions at the level of the head. We ended up with 3 groups. We decided also to subdivide high velocity bullet groups, so bullets ejected from the M16 and the K-47 from submachine guns due to their different muzzle velocities. So with the statistical analysis of entrance wounds show no significant difference from conventional handguns and submachine guns along with high velocity bullet group, with only a slight increase in the average values of submachine guns. For the exit wounds, the difference between submachine guns and controls along with high velocity bullets and controls were significant. So the damage was actually more extensive. When it came to the exit and entrance ratio of the wounds, only the results of the high velocity bullets were when compared to the controls were statistically significant, while the submachine guns were not. So why were the entrance wounds similar among the different groups? This could be explained by the fact that upon impact with the cutaneous surface, we have temporary involution and stretching with subsequent recoil of the cutaneous surface, meaning that the actual size and morphology of the entrance wound will not reflect the caliber of the bullet. Not always. The exit wounds of both the submachine guns group and the high velocity bullet group were larger than controls, mainly due to the fact that they have higher residual kinetic energy upon exit from the body cavities. Whereas we said that only the exit and entrance ratio was higher, the exit entrance ratio was higher only in high velocity bullet groups, meaning that there is still a substantial difference between high velocity and low velocity bullets. So in this case, we can see how this study is actually useful in the detection and recognition of the type of damage caused by small arms, especially when it comes to military small arms. So in this way, we can see how this is relevant and also to assess in any setting what is the meaning of this type of study. And this is relevant for both the forensic pathologist in the reconstruction of the dynamics of the event and also to determine the type of arm that was involved, and also the emergency physician to provide appropriate care to the patient, to the critical patient affected by gunshot wounds. So we would briefly like to thank Lorenzo Gitto and Ponia Rankumer from Chicago, which provided a control group and were super useful for analysis, and also Professor Moras Vanarak from the Department of Maydol University, which is very happy to collaborate with us.
Thank you, Anna Maria Demanta. Thank you very much, and congratulations for your presentation. I have to ask to the Commission if there are questions for the candidate. I have a question of Anna Maria, and because I'm curious about the clinical implication of these findings. I mean, you mentioned that at the end of the thesis that there are some implications for the physician of the emergency the room. Could you say more about that?
Yeah, mostly due to the temporary cavity effect, because we have some organs that are more affected than others. For example, all organs are usually easily displaced by the temporary cavity and not produce extensive damage. While in the case of solid organs, including the spleen, the liver, and also the kidneys, damage can occur and cause also laceration with the propagation of discharge products. So this is mostly we should also say something about the head, which was excluded from our analysis because it produces highly destructive lesions when it comes to high velocity bullets. So for that, we should perform we should start another protocol to quantify the actual damage because it is an inextensive mortality. So the pressure waves are even more disruptive.
Professor Ciavella, you are the supervisor, and they have to ask you formally if you are satisfied by the work of the candidate.
Yes, yes, thank you.
Okay, thank you very much. So it's the time of the next candidate. The next candidate is Doron Theodor Shemi. Doron Theodor Shemi is presenting the thesis. The title is Atypical Teratoid Rhabdoid Tumor in Adults. Case report and the comprehensive review of the literature. The supervisor of the thesis is Professor Felicia Giangaspero. Please, Professor Giangaspero, please introduce briefly the candidate and the thesis.
The brain tumors in children are completely different from adults, but sometimes some tumor we get rid of the pediatric cannot go enough. And because of the rarity, this type of tumor, they are reported as a single disease. So I asked to do a meta-analysis of the literature about the performance in adults of this very rare tumor, which is a different tumor, which has a specific medical case. So,
Atypical teratoid rhabdoid tumor was first described by Rock et al. In 1996. Atypical refers to the teratoid component showing 2 or more lines of differentiation, while rhabdoid marks the presence of rhabdoid cells similar in microscopy to skeletal muscle tumor origin. It is defined by the WHO as grade 4 embryonal CNS neoplasm. It is a highly heterogeneous lesion with polyphenotypic differentiation and variable immunoreactivity, all of which render this tumor difficult to diagnose in some instances. It is a rare pediatric tumor encompassing 1 to 2% of pediatric brain tumors. Yet, it is the most common malignant brain tumor below the age of 6 months. Prognosis is poor, with median overall survival of 11 months. Adult cases are extremely rare. ATRT can occur sporadically or as part of a rhabdoid tumor predisposition syndrome. SMARCB1 or INI1 alteration is considered a genetic hallmark of ATRT, while SMARCA1-BRG1 alteration is very rare. Both are components of a chromatin remodeling complex, and loss of these components results in deregulation of cell cycle, cell survival, and differentiation. The DNA methylation profiling of ATRT has shown that it is not one single entity, but in fact consists of 3 distinct epigenetic subgroups associated with differences in age, gender, location, type of genetic alteration, unregulated pathway, and even radiological manifestations. Currently, therapeutic strategies are extrapolated from pediatric literature. Due to the limited data available and heterogeneous inclusion in case reports and case series, little is known about the characteristics and impact of ATRT in adult population. This study aims to demonstrate the characteristics and impact of ATRT in adults and potentially serve as a reference tool for further studies and therapeutic decisions. Therefore, we conducted a systematic review of literature in accordance with PRISMA guidelines to identify cases of ATRT in adults. Database search was made in PubMed and Google Scholar using search terms atypical teratoid rhabdoid tumor and adults. Reference search was done as well. We only included cases above the age of 18 with a characteristic neuropathology and with a confirmed alteration of INI1 or BRG1. A case from our department was included as well. Database and reference search identified 480 articles. Initial screen and duplicate removal yielded 180 articles, of which 139 were assessed for eligibility with a full text review, resulting in 74 articles and 92 confirmed cases. Together with our case, we generated a patient pool of 93 cases. Of the 93, the mean age of diagnosis was 38.8, ranging from 18 to 80. and female gender encompassed 72%. In terms of tumor location, the most common location was the supratentorial compartment with nearly 84%, followed by infotentorial and spinal cord. CSF dissemination was in nearly 20%, while extramural dissemination was in more than 8%. Local invasion was in a third, while recurrence occurred in more than 45% of patients, some of which even after gross total resection and combined adjuvant therapy. Cellular location was in nearly half of patients, followed by cerebral hemisphere. And interestingly enough, cellular location occurred almost exclusively in female. In terms of intervention, incomplete surgical resection was the most common surgical intervention applied. Tumor location, extent of invasion, and preoperative patient condition altogether affected the degree of maximal safe resection possible and rendered gross total resection difficult to achieve. On the other hand, combined chemoradiotherapy was the most common adjuvant applied, and in fact, when applied with surgical resection, encompassed 83% of alive at follow-up. 43% of total patients were alive at follow-up, with more than half without evidence of disease. More than half succumbed to the disease, with median overall survival of 15 months. Midline tumor location was significantly more prevalent among female gender and above the age of 40 years. There was no significant differences in survival when comparing the extent of surgical resection. Conversely, there was a marked increase in survival with the application of combined adjuvant therapy when comparing against adjuvant therapy modalities or in comparison with surgical resection and combined adjuvant therapy. Overall, the highest improvement achieved was with a surgical resection and combined adjuvant therapy. In addition, there was a marked effect on survival associated with Ki-67 score in histology. Ki-67 score higher than 40% may indicate a more aggressive tumor behavior. This study described the patient demographics, tumor characteristics, treatment, and survival in adult ATRT population. Adult ATRT is an extremely rare, predominantly supratentorial tumor with female gender predilection and propensity for CSF dissemination. Maximal safe resection with combined adjuvant therapy could be the optimal therapeutic strategy. All neuraxis imaging at presentation may allow early detection of disseminated disease, while a Ki-67 score may indicate a more aggressive behavior and help in patient prognosis stratification. Recent insights into the molecular genetics and biology of ATRT have opened the door into novel molecular therapeutics and immunotherapy. Further investigation is needed to refine the diagnostic tumor classification, facilitate early detection of disseminated disease, identify predictors of survival, and lay the foundation for target therapy. Thank you. I wish to dedicate this thesis to my best friend and my soulmate, my wife.
I just would like to ask you what symptoms, which are the most common symptoms of the supratentorial patient, and how is the progression of the how does it progress?
In terms of symptoms, the most common symptoms were headache, nausea and vomiting. Some were with seizures, and generally they were related to the location of the tumor, particularly in the supratentorial compartment. Some presented with a cranial nerve deficit, and in terms of the more there was a mass effect and potential occlusion or hydrocephalus, there was potential of herniation and a more dramatic presentation of the patient. Thank you very much.
So the next the candidate is Ziad Ayman Al Sayed Abdul Baed Taha. The title of the thesis is the role of the liver transplant unit in the therapeutic decision-making for hepatocarcinoma, evidence-based versus the precision-based medicine. The supervisor of the thesis is Professor Gianni Stefano Corradini. Please, Professor Corradini, could you introduce briefly the candidate in the thesis? Thank you.
Thanks. Good afternoon to everybody. Liver cancer, and especially hepatocellular carcinoma, is frequent, is deadly, but there are few options, therapeutic options, including liver transplantation. These options are contained in algorithms, but these algorithms very often can't be applied to the single patient. So multidisciplinary work is very important to assess which is the best treatment for a certain patient. We are performing these meetings or multidisciplinary meetings every week. So I asked to Ziad to look at the outcome of this in terms of being within the algorithm or outside the algorithm. In other terms, whether it's worth to do all this or if we can just apply the algorithms without any particular different decisions from the algorithms. Please, Ziad.
Thank you, Professor Corradini. Good afternoon to everybody. Our research is going to address hepatocellular carcinoma and autism. Yes. Good afternoon, everybody. Today we're going to speak about hepatocellular carcinoma, the management, and how can precision medicine change the management expected from it. Okay, so a bit of an overview. Hepatocellular carcinoma, referred to known as HCC, is the most common, making up 90% of primary liver cancers. It's the most common cause of death in cirrhotics, and it is usually staged, and staging and treatment are made by the BCLC guidelines. So the Barcelona Clinic Liver Cancer Guidelines provide the staging and the treatment, and it's adopted by the European and American Society of Liver Cancer. It provides important prognosis and determination of therapy. This is a review of BCLC guidelines. As you can see, it divides patients into 5 different stages, from stage 0, very early disease, A, early, B, intermediate, C, advanced, and D as terminal disease. As you can see at the bottom of the screen here, we also divide treatment into 2 groups. The first being curative. We have surgical resection, liver transplantation, and radiofrequency ablation. And this treatment is reserved for stages 0, A, and no, yeah, only A. Then we have the other treatment, it's not curative, it's reserved for B, being TACE, transarterial hemoembolization, where interventional radiologists insert chemotherapy inside the lesion. Furthermore, for stage C, we have sorafenib, which is a tyrosine kinase inhibitor, and the BCLC staging system recommends palliative treatment for stage D. So the BCLC guidelines are quite restrictive and limiting because it's not quite taking into all the clinical variables of the patients. Here I show you 4 different patients, all of them belonging to class B, but all of them have different comorbidities, different treatments, different aspects of the cancer, and also different outcomes. So here, the role of precision medicine. That is, it is a medical model that purposes treatment being tailored and specific to patients instead of adopting a one-drug-fits-all system. This often comes in handy in
wherever the guidelines are not good enough or they do not give us the best treatment possible. This is provided by a meeting of different specialists of different experts who come together, discuss patients in a very detailed way, and come up with the best therapeutic plan. At Polyclinic Giugno, we provide, Department of Gastroenterology, we provide this medicine through the literature, referred to as LTU, and also the tumor corridor. We will be discussing the transplant because these are patients interested in. So, one thing about the role of the transplant unit, which came into play in the late 90s, is that we still do not have a complete correlation in how it differs from CLC staging and treatment guidelines. For sure, there are multiple studies, but they're not enough to establish how can the role of precision medicine change the therapeutic plan. So we aim at rather role of multidisciplinary approach, comparing the treatments decided in the literature to those ones recommended by the BCLC therapeutic guidelines. We try to establish how a panel of specialists can choose treatments which do not fall under the most commonly used guidelines. In our observational study with patients of 18 years and older with a clinical diagnosis of cirrhosis and HCC, no prior HCC-specific treatments, and we looked at patients from the period of 2019, and of course, for consent. Our study was 101 patients. So what we did was look up written records of the liver transplant unit meetings, and we identified certain clinical criteria of patients that made us classify them into the respective staging. Then we compared the treatment plan by our team and compared it to the BCLC staging to see if there was a need for the impact of the LTU on the treatment. Here's a graph showing most of our results. So out of 101 patients, we had 14 of stage 0, 12 belonging to stage A, 61 patients in stage B, no patients in stage C with total knee invasion, and finally 14 in stage D. Over here I'm showing the columns are color-coded, indicating in red, as you can see the legend right down, red means LTU decisions, which means that these patients, this class has a treatment which is not recommended in the BCLC guidelines. Over here we look at this specific aspect in more detail. So if you look at, for example, in BCLC 0, we see that in blue are the treatments recommended by the BCLC guidelines, which is radiofrequency, ablation, and resection. But out of 14 patients, our team found that TACE was beneficial too, and decided to wait on 3 other cases, like we're still following them up. Again, in BCLA, we decided to treat 5 patients with TACE, which is not recommended by the BCLC guidelines. As you can see, TACE is reserved for only stage B, and it was used in almost, our team decided to use it in almost every single group. And finally, we see in stage D, all the columns are red, because as we said before, the BCLC guidelines recommend that we give only palliative treatment to this class. But our team decided that these patients were eligible for treatment, HCC-specific treatment, and they were treated accordingly. Here I'm showing one specific thing that highlights the holes, the weaknesses of the BCLC stage, where as you go further in class, as the patient becomes more ill, as the disease advances, there are more comorbidities and the clinical picture becomes quite complex. And here is, I'm showing the trend, the positive relationship between increasing severity of the disease and the percentage of patients which receive a different treatment than the BCLC staging. As you see in class A, there are only 4 patients out of 14, 30%, and it rises to 40, 50, and finally in stage D, 100% receive different treatments. One other point that we would like to mention, the guidelines
restrict liver transplant to only early stage A, but in our center we use a different criteria for transplant, which is the up to 7 criteria developed by Professor Mazzafero. And these results show how many patients were, according to the criteria, not eligible for even evaluation of liver transplant, but we actually managed to evaluate them. Some of these patients, of course, were not put on the list, but a lot of them were. And we even have data right now that we're working on which show, I think, 3 patients of class B, which should, according to guidelines, receive palliative treatment. These received liver transplant in past years, and till now we're following them up. They're healthy and alive. I'm very happy. So, in conclusion, I would like to mention, as I was saying all this time, that BCLC staging and some other guidelines are should not be considered sacred, and sometimes they don't give us the best treatment plan. And the only way we can overcome this is that if we gather the expertise on this specific topic and have their opinions, making a tailored therapy that would improve mortality and life expectancy of these patients, especially in our case here, classes B and D. We encourage the use of multisystemic approach as well as HCC. And finally, I would like to say that 100 patients are followed in the hopes of creating another study comparing the mortality of patients of our group to the mortality expected by the BCLC guidelines. Finally, I'd like to thank the committee, my friends, family, and all the resources that we need from here. Thank you. So when I say that the BCLC system is not a true representative, I don't mean that we need to throw it out completely. It still has value because, as we've seen, 50% of our patients fell under the criteria, and the experts' opinion of our hospital found out that the best treatment for these patients were the ones which coincided with the BCLC staging. Nonetheless, I would, of course, always push towards a multidisciplinary approach, but understanding the value of guidelines and providing standard of care to all the world, where in places that you cannot have a multidisciplinary approach, you need guidelines like this. So, of course, we're not saying to completely abandon guidelines, but keep them always updated with new research, and we hope that our research can contribute to such an update.
Thank you, President. Good afternoon to you all. Maggie, performance investigate what happens after menopause in these patients. You know that during that age, the patient has severe pain, and this affects the quality of life of these patients. But there are no data after menopause. And Maggie performed her study despite the COVID restriction by contacting the Association of Women with Endometriosis, and the results are very interesting. Maggie, it's okay.
Good afternoon to everyone. Good afternoon, President Guilherme. First of all, I would like to say thank you to Professor Porpora for her support and guidance during this project. So I'm going to present my thesis on clinical features and quality of life in patients with endometriosis before and after menopause. How can I move it? So, endometriosis is a chronic estrogen-dependent disease which has a prevalence of 6 up to 8 and 10% of the fertility age women, but does not occur exclusively during the fertility age, but even in other stages of the age. So, it can give rise to pain symptoms such as dysmenorrhea, dyspareunia, and chronic pelvic pain, but even infertility, and it has a strong impact on the quality of life. Although there is no cure definitively for endometriosis, all the conditions that trigger hypoestrogenism have been proved to be viable alternatives for the control of the disease. So what happens after menopause? In most of the cases, the menopause-induced hypoestrogenism gives rise to a reduction of lesions and improvement of symptoms. But on the other side, there can be active foci of disease that cause persistent pain. Up to now, in the literature, there are few data regarding the quality of life and clinical characteristics of the patients with endometriosis after menopause, and there are no data regarding the hormonal replacement therapy used in women with a history of endometriosis in menopause. So the aims of our study were to evaluate the clinical characteristics and quality of life of patients with endometriosis before and after menopause, and secondarily, to analyze the frequency of the hormonal replacement therapy used and its effects on disease and symptoms. So data were collected from self-recruited patients of the endometriosis and pelvic pain outpatient service of Policlinico Umberto I in Rome, and from patients coming from the Italian Endometriosis Association. The inclusion criteria involve clinical instrumental or histological surgical diagnosis of endometriosis, but even a certain menopause which occurred spontaneously or surgically induced. So with consent, we recruited 163 patients with an average age of 45.13 years old, an age at menarche 12 years old, an age at menopause 14.7 years old, and an age at diagnosis of 31 years old. Data were collected because patients were asked, and they actually fulfilled a questionnaire which investigated upon questions: age at menopause, age at diagnosis, pain symptoms such as dyspareunia and chronic pelvic pain with their relative scores based on the visual analog scale, NSAIDs use and other drugs intake before and after menopause, hormonal replacement therapy use and its duration, and very importantly, quality of life. Quality of life was assessed by one part of the EHP 30 questionnaire, which is a validated questionnaire especially designed for patients with endometriosis. And it has the part that we use in our study, 5 scales for a total of 30 items. And it investigates pain, control and powerlessness, social support, emotional well-being, and self-image. In our study, we found out that after menopause, there is a significant decrease in all the lesions and their respective size. But there is a persistence of non-specified lesions in only 9.8 of our patients. Furthermore, there is an endometrioma size decrease from 43 millimeter to 39.6 millimeter. And in terms of pain symptoms, the chronic pelvic pain significantly decreased, but interestingly, dyspareunia was found to be increased. And there was found actually a correlation with vaginal dryness, which assumes that this dyspareunia in our patients is a superficial one. And in the other side, vaginal dryness was correlated with a decreased libido. So all these factors together probably bring a poor sexual life in these patients. The menopause occurred spontaneously in most of our patients, but only 32.5% took hormonal replacement therapy for about 3.86 years. And although in our study was not statistically significant, pain symptoms decreased in the subgroup of patients. Most of our patients presented with the typical symptoms of menopause, such as hot flashes, weight gain, depression, insomnia, decreased libido, and vaginal dryness, but few of them reported cardiovascular diseases and osteoporosis. And as we can see from the chart, the quality of life improved in most of our patients, while 30% reported a worsening, and the remaining had no change before and after menopause. And from the table, we can see that the significant improvement was in terms of pain, control and powerlessness, social support and emotional well-being, but the self-image actually didn't change. So we can conclude from our study that there is a significant improvement of endometriotic lesions, pain and quality of life after menopause in patients with a history of endometriosis, despite the superficial dyspareunia, which might contribute to pure sexual life. In addition, hormonal replacement therapy seems to improve the health-related quality of life, although from our study it was not possible to evaluate the real impact due to the small sample size. Only 32% of our patients actually were on hormonal replacement therapy. We can notice that there is a fear of the patients to undergo hormonal replacement therapy because of the activation of the lesions. So this shows for us a need for counseling in order to make them aware of the benefits that can be possible in our patients. The only limit of our study is that the patients were self-recruited, but we need to emphasize the strength of the study. This is the first study to demonstrate the better quality of life in patients with endometriosis in menopause, which is assumed to worsen in the general population. So as future prospects, we suggest the use in further studies of larger samples and also an extensive use of both core and supplement domains of the EHP 30 questionnaire. This is the end of my presentation. Thanks to everyone for being here and your attention.
Thank you very much, Maggie. Congratulations for your presentation. I have to ask the two professors if there are any questions for the candidate, because they have the question, Maggie. Because if I understood well, you had missed the same questionnaire to women in menopause. Only on the menopause, but asking the situation in menopause and before. What do you think that this could be a bias in your study, in your?
Yes, this is actually, Professor, a very interesting point, because the bias can be even in terms of the patients considering themselves in menopause, but actually not being in menopause. And we did our best to investigate through the questionnaire those women that were actually very young. We had answers from patients of 32, of 26 years old, and we didn't include them in the study because we saw from the questionnaire that they were on hormonal therapy. They were taking the combined pill, for example, and they were having vaginal dryness and the decreased libido, so they consider themselves in somehow menopause, but this is actually, they are actually not in menopause. It's the effect of the pill. So we try to exclude that. And another bias is that, as we can imagine, the patients who are more interested to fill the questionnaire are those with the worst symptomatology. So we can have even many other patients that have actually that are actually in menopause but don't answer because they are actually in a good general health state. Thanks.
So the next candidate is Amir Khan. Amir Khan is presenting the thesis. The title is the comparison of the outcomes in terms of effectiveness and safety of non-medical switch from a biooriginator to a biosimilar, or between different biosimilars of the same biooriginator in patients with chronic arthritis. An observational study. The title is very long, also very complex, but here the supervisor, the professor, Rosanna Scriva, they will introduce briefly the candidate and the thesis. So please.
Yes, thank you, President, and good afternoon. So this is an interesting study on the non-medical switch between biological agents in patients with chronic arthritis. Biological agents have revolutionized the outcomes of patients with chronic arthritis. However, due to a high cost, they pose a significant and financial burden on the healthcare systems all over the world. So the availability of biosimilars, which are less expensive, is promising to increase the accessibility to these drugs for many patients. And indeed, many scientific societies have dictated a sort of a mandatory switch from the bio-originator to a biosimilar for economic reasons. This is called a non-medical switch. So we decided to investigate the comparison of effectiveness and safety in these two kinds of switching patients with chronic arthritis. And this is very interesting because we have no data at all currently on the switch from a biosimilar to another. So please, Amir, tell us what you found.
Oh, can you hear me? So thank you, Professor, for the introduction. I'm not going to read this again word for word. The professor very eloquently summarized a shorter title. So the topic of the title is a non-medical switch in between biological agents. So our conversation starts here. What is a biological agent? Biological agent, while there is a very specific definition by the European Medicine Agency, we say that a biological agent is a very complex molecule that is produced only in living cells to recreate this complexity. And biological agents are used in very many different fields of medicine. In our practice in rheumatology, we say that there are very many mediators of inflammation that are involved in the treatment of chronic inflammatory diseases. And considering that also there are many different mediators, but also many drugs that target each of these mediators. For the purposes of our study, I'll mention one, TNF-alpha. And one specific anti-TNF drug is called adalimumab. Adalimumab, which was the best-selling drug in 2020 and even the years before this. It's indicated in clinical practice for chronic inflammatory diseases like the three you see on the screen. These diseases we'll get back to. However, the indications to actually start this disease are in moderate to severe disease, validated by the clinical metric indexes that we use in practice, alongside the clinical judgment of the rheumatologist. That said, so while adalimumab was the highest grossing drug of all these years, not only because of its wide span of clinical use and efficacy, also because it's a very expensive drug, like the professor noted. With more and more of these patents coming to an end of the bio-originated drugs, an alternative option comes to fruition. And these are biosimilars. A biosimilar is a biological product that is highly similar to the reference product. One could make the comparison to a generic drug, where a generic drug is a complete identical chemical copy of the original. A biosimilar, because it's produced in a biological system, in a living cell, we say that there's always some small amount of microheterogeneity, small differences in the glycosylation here or folding there, differences in structure. Regardless, the point is this: there are no clinically meaningful differences in terms of safety, purity, and potency. And because of the lower cost approval pathways of biosimilars, they're estimated to reduce drastically all the spending on biologics. So our study is here. While there are no reports on the switch from a biooriginator to a biosimilar, while there are, plenty of reports on this switch, there are no studies on the switch between a biosimilar and a biosimilar. The next slide will explain a lot more clearly that we are evaluating the effectiveness and the safety of these two parallel arms, as we can see here. So one by one, we see that we started with a study sample of 150 patients. And on the left side, let's say, there were the patients who switched from a biooriginator to a biosimilar SB5. And on the other hand, the parallel arm, we had the patients who switched from biosimilar ABP 501 to SB5. Regardless, when these patients stopped taking the first drug and were then made to switch, we call this time period T0. And then at the same time, when we were making the appointment for the 4-month follow-up, we call this period T4. Very important, one more time, I'll reiterate, is the fact that this was a non-medical switch done for economic and administrative reasons. So that said, what are the things we were measuring at T0 and T4? On the left, you can see that there were some laboratory values. On the right, there were patient-reported outcomes, subjective experiences as given by the patient to the rheumatologist. And at the bottom, there are the disease activity indexes. These involve the laboratory values, the pain indexes, and the clinical values that are taken at the appointment. And then we begin with the results. Here we can see that there are more or less a 50-50 split between males and females. The median age was around 56. The median BMI was around 26. The median duration in which patients were taking the first biologic was considerably greater or longer in the biooriginator. On the right-hand side, you can see the smoking status in which patients had, the majority had never smoked. Okay, so here we have a graph that will be the prototype of how we report our data. This is one of the disease activity indexes, specifically the DAS28 CRP. It was specifically for the rheumatoid arthritis patients. So this is what we do. We record the median values. We take the 25th and the 75th percentiles. We record them at the T0, the T4, we document them, but then we also statistically compare the T0 to the T4 to see if there was any difference between the two. Ideally, what we want to see is that it doesn't get worse, obviously, at least stays the same, because if in fact they were equivalent, then switching to the cheaper drug is the better option if it causes no harm to the efficacy or the safety. And in fact, this is what we see. If we take the blue on the left, the biooriginator switch, there was, with the p-values reported underneath, there was no significant difference between the values at T0 and T4. This we already knew. This was already in the literature. The aim of our study was the biosimilar switch on the right, which is the same story. The p-values underneath are non-significant, meaning, again, there was no statistical difference. And we say the same for the other parameters. In fact, we say exactly this. The DAPSA score, which is specific for psoriatic arthritis, one of the arthritic diseases. And on the right, the BAS-DAI score, specific for ankylosing spondylitis and psoriatic arthritis with axial involvement. The point is that all the p-values you see here in both the biooriginator and the biosimilar switch were non-significant. There was no difference. Interestingly, though, we did see one thing. So let's start with the biosimilar switch. These were the patient-reported outcomes, the subjective experience as reported by the patients. With the biosimilar switch, if we start in the red, there was no significant difference as reported by the p-values. The biooriginator switch, however, maybe controversially, there was a statistically significant worsening on the patient who started taking the biooriginator and then switched. And then the last aspect of our study, I'll take the example of the adverse events, in which 3 out of a total of 40 patients in the biosimilar switch reported like there was an absolute number of adverse events. Likewise, the 5 in the very top, the 5 out of the 110 patients reported adverse events. Again, on the right-hand side, we see the p-values were all non-significant, no difference between the two. In conclusion, this was one of the first studies ever done that compared the switching from 2 biosimilars of the same biooriginator. Our data suggests that both these options, starting on the adalimumab, switching to a biosimilar, and switching from one biosimilar to another, could be good options in patients with chronic inflammatory arthritis. That said, however, we did see the differences, and they do need pointing out in the subjective, the reduction in the subjective effectiveness. Now, to try to explain the effects, could it be because of a nocebo effect? In any case, what we need to do is conduct more studies to confirm the differences we found, but then further one step would be to see if the differences are psychological in origin. I'd like to take a second to thank you all for your attention, to thank
Dr. Chiari Castellani and Julia for really helping me get here. And all my colleagues in class, it's really been a pleasure to study this one.
Thank you very much, Amir. Thank you. Congratulations for your presentation. Are there any questions by the committee? Please, Professor Berardelli.
Do you think that your conclusion can be extrapolated also to other conditions? Medical conditions?
Sure. Biosimilars are used by, for example, pediatrics and dermatology. There was a slide. Biosimilars as a drug in themselves are just like biologic agents, and they target something, some mediator or some molecule or even some receptor, like in immunology or hematology. I think they could be, because the mechanism of action is the same. Without looking at this translate to whether the field of medicine or the other diseases, I believe they will.
Okay, the Professor Scrivo, are you satisfied with your supervisor?
Yes, I am.
Thank you very much, the Professor Scrivo. Okay, this is the time of the next the candidate. The next the candidate is Daria Karim. Daria Karim is presenting the thesis. The title is The Cutaneous the Manifestations of COVID-19 in Children, Comparing Experiences among Different Ethnic Groups. The supervisor of the thesis is Professor Antonella Tammaro. Please, Professor Tammaro, could you introduce briefly the candidate and the thesis? Thank you.
Thank you so much, President. And I'm glad to introduce Daria Karim. She's from Finland, but she has Iraqi origins. For this thesis, she has had an important collaboration with Dr. Azo, a pediatrician in Suleimani University of Medicine in Iraq. The project was performed with Spallanzani Hospital 2 in Rome. A group of children with lesions from COVID-19 has been studied, and now Daria will present you our findings. Enjoy your presentation.
Thank you, my wonderful Professor Tammaro. Thank you to the committee. Thank you to Professor Della Rocca and Professor Villari. So, this is better. Wonderful. Before I start, I'd like to say thank you for our collaborating doctor, Dr. Asa Saleh from University of Suleimania, Kurdistan, Iraq. Now, as we all know by now, COVID-19 is an infectious disease caused by the severe acute respiratory syndrome, coronavirus 2. It was initially considered primarily a respiratory disease. And when we look at the literature, we noticed that cutaneous manifestations were not reported in the beginning. And also children were thought to be unaffected. Now, this was until temporal association with Kawasaki disease and COVID-19 was found in children. This is a graph that we can see from the Bergamo Hospital over 5 years, and we can see cases of Kawasaki disease. And as we can see in 2020, there was a massive increase in Kawasaki disease cases. Now, patient 0 was confirmed in January 2020 in Italy. And when we found out about this temporal association between Kawasaki disease and COVID-19, a study was made to assess this child that was diagnosed with Kawasaki disease several months prior to Italy's patient 0, and she actually was confirmed to have a SARS-CoV-2 infection. This Kawasaki-like disease later on gained the name multisystem inflammatory syndrome in children, which is a severe presentation of SARS-CoV infection in children. Now, when we look at skin manifestations, we have a vast range of presentations from asymptomatic children to severe presentations of COVID-19. Now, one of the most frequently reported skin lesions we had are the following. In particular to our study, what we found most commonly is chilblain-like lesions, maculopapular rash, vesicular lesions, and mist-related exanthems. Now, what we aim to do is assess these cutaneous manifestations in patients between the ages of 0 to 16 years old that were infected with SARS-CoV-2. We also wanted to classify these lesions and analyze the relationship between the skin manifestation and the severity of COVID-19. Now, our study population was pediatric patients that were infected with the novel coronavirus that visited Spallanzani and Sant'Andrea Hospital in Rome and the Pediatric Teaching Cardiac and University Hospital in Suleimania, Iraq. Our study sample was 79 patients. We included both asymptomatic and symptomatic patients with cutaneous manifestations and a positive diagnosis of COVID-19. Now, for our study, we selected 36 out of the 79 patients. They were from 0 to 16 years old. 86% of them were cases of MISC, and 14% were primary cases of COVID-19. And as we can see from the table, our mean age was 6.5 years old. Males had a slight majority. One thing that was common was GI symptoms. Respiratory symptoms weren't so common in our study population. Fever represented in almost all of the patients. Cardiac involvement was represented in 25%. Coagulopathies were very common, and we also experienced a death during our study. Now, out of the 79 patients, 55% were COVID-19 cases without skin manifestations. 39% were cases of MISC, and 6% were COVID-19 with skin manifestations. Now, here's a table that signifies one of the most frequent manifestations our MISC patients had, and one of the fundamental differences we were able to find is that between Kawasaki disease and MISC is the prevalence of GI symptoms, as well as prevalence of respiratory symptoms, lymphopenia, thrombocytopenia, and immunological symptoms. And I want to mention that our MISC patients had a higher mean age than those usually in Kawasaki disease patients. Now, I extracted a few clinical cases from our study to show you the lesions we detected. This was a year-old female who was referred to the pediatric cardiologist due to an acute case of heart failure. Because of a dilated cardiomyopathy, she had a laboratory confirmed infection, presented with no respiratory symptoms, and later on developed left-sided hemiparesis of the body and right-sided hemiparesis of the face. Now, several days later, she presented with arthritis with multi-joint involvement, also a vesicular skin rash on the arm, as we can see. She was diagnosed with MISC according to the CDC criteria. On day 20, all of the symptoms and signs had subsided, but the heart failure still persists. This was a young female who presented with fever, irritability, and skin rash. We can see this vesicular skin lesion all over the trunk, the limbs, and the face. This was a young male who only presented with skin manifestations. He had a positive household contact. He presented with acne skin darkening, peeling of the skin, and maculopapular rash. Now, this was a 10-year-old female who was referred to the pediatric cardiologist due to coronary aneurysm and prolonged fever. She developed both maculopapular rash and vesicular lesions, and we found an interesting correlation between increasing D-dimer levels and the increasing severity of the skin rash. Now, a 9-month-old male, she was admitted due to unexplained fever. On day 6, he developed a morbilliform rash, and he was also diagnosed with MISC following the CDC criteria. Lastly, a 7-year-old previously healthy female presented with fever, myalgia, abdominal pain, and loss of taste. She developed a maculopapular rash on the 9th day from onset of symptoms. Also on echo, we found pericardial effusion and thickening, yet another case of MISC. Now, what are we able to conclude with our study? Well, it is evident that cutaneous manifestations are part of COVID-19 in children. There's a vast range of skin involvement when it comes to children infected with the novel coronavirus. With respect to our study, we found two ends of the severity scale. We had children that only presented with skin manifestations and had a very mild presentation of COVID-19, and we had those who presented with skin lesions as part of MISC. So a take-home message here would be that we should never overlook the skin. We should use dermatology and its tools to not only aid with prompt diagnosis and treatment, but also to understand the pathophysiology of the disease better. Now, I want to just keep in mind that these skin lesions can be a consequence of a direct viral infection. They can be due to immune dysregulation, or rather coagulopathy, or even side effect of a drug. Also an altered immune status that can lead to reactivation of another virus. Now, lastly, I want to say thank you to Dr. Asaf Salih in the Pediatric Department, College of Medicine, University of Suleimania in Iraq, and Spallanzani Sant'Andrea Hospital in Rome, Italy. Thank you to my wonderful professor. Thank you to my family up there. Thank you. Thank you.
You.
Thank you very much for the study. That's very interesting. Apart from this patient, where skin lesion is part of the clinical diagnosis.
So in our study, only 6% of the patients were simply mild cases of COVID-19. The rest were cases of MISC. 6%. Yes. 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 The reason being is that in Kurdistan, where we conducted this study on partnership with this study, is that the healthcare system works in a way where only the severe cases will be detected. Therefore, the mild cases will never be reported or detected. Therefore, there can be a bias there as well.
The candidate.
Yes, I am.
Mhm.
I want to
If it is a long concept, you have to come here because otherwise they cannot hear you.
again with Dr. Aso about long COVID. It's very important this because we saw a lot of the patients that after 6 months, they present skin lesions on the skin. A lot, rash, urticaria, and all the manifestation, but we need more time to study about this.
Okay, thank you very much, Professor Tammaro. Congratulations again to Daria. Thank you very much. Now it's the time of the next candidate. The candidate is Armando De Muro. Armando De Muro is presenting the thesis. The title is Predicting Length of Treatment in a Sample of Migrant Patients with Mental Disorders. An observational study. The supervisor of the thesis is Professor Lorenzo Terzitani. Ciao Lorenzo. Lorenzo Terzitani will introduce briefly the thesis and the candidate. Thank you very much, Professor Terzitani.
Thank you, Professor Pilleri, Mr. President. Good afternoon. Armando Muro, our session for Migration Psychiatry, and get the opportunity to participate in each phase of a study on treatment duration and on treatment adherence. Because in psychiatry, treatment adherence and dropouts are a major problem because they are strong risk factors for worse outcomes, for any kind of worse outcomes. And we are trying to study these possible risk factors in these longitudinal studies because in immigrants, they are really understudied. Armando?
Thank you, Professor, for the introduction. This is Brazil. Professors, parents, and colleagues, I'd like to talk to you about an observational study conducted here at Polyclinical to try and predict length of treatment in a sample of migrant outpatients and disorders. Migration is one of the defining phenomena of our time. This is the beginning of the 20th century, an association between the development of mental disorders and migration has been discovered, especially regarding psychotic disorders. For this reason, the literature devoted to exploring all different factors regarding the migratory process and their impact on a migrant has been constantly increasing. And all these factors have been categorized according to the time in which they occur during the migratory process. We can divide it into pre-migration, migration, and post-migration factors. All we need to know about it is that they can be either one-time or low-intensity traumas that last the entirety of the life of the individual. Migrants have also shown to face particular hardships when it comes to accessing mental health care. These kinds of barriers are structural or versatile. The structural barriers regard policy implementation for host country in relation with the migrants, especially whether if they're documented or not. The versatile barriers instead are related to the unique individual structure of the patient and the background. And they can produce themselves as unique cultural mediums of distress, no perceived need for treatment or cultural stigma. Migrants also show increased rates of dropout from mental health services for reasons that may or may not be connected to the migratory process. More importantly, particularly, migrants have shown a higher tendency of expressing symptoms that are not traditionally considered core symptoms of their categorical diagnosis. For this reason, the categorical approach is deemed insufficient to understand psychopathology in migrants, and a dimensional approach is being suggested. Psychopathological dimensions are to be superior and categorical diagnosis in different aspects, whether it is tailoring pharmacological treatment or understanding a patient's functioning improvement or lack thereof time, and predict clinical outcome and length of treatment. The most common dimensions explored in the studies that use this approach are these five that you see here: positive symptoms, negative symptoms, activation, affect, and disorganization. These are also the dimensions that we will explore in our study. The aims of our study, beyond analyzing and describing our sample, is to test the role of general psychopathology in the prediction of effective treatment and to explore the effect of specific psychopathological dimensions in the prediction model. Our study sample is composed of 168 economic migrants, refugees, and asylum seekers recruited here at the Outpatient Service for Migration Psychiatry at the Department of Neurosciences and Mental Health at Polyclinic Umberto I. All patients signed a verbal consent form after a verbal explanation of the meaning of the study and the meaning of their participation to it. And data was collected using the expanded Greek psychiatric rating scale, which is a worldwide accepted tool to measure mental functioning in patients over time, and the stress-related vulnerability scale, which is a scale that regards perceived stress. It's a self-administered scale with scores that are rated on 3 subscales, which are tension, demoralization, and lack of social support. Moving on to some descriptive data of our sample, we can see that it's predominantly male, 65.5%, and it's a relatively young sample with a mean age of 36.9 years. We can see that roughly 1/3 of the sample is in a relationship, while the other 2/3 is not. And if you look at the pie chart, the educational status, you can see some interesting data highlighted in red. 15% of our patients have either a university degree or a higher title. This is a much higher percentage than the general population. And this could be, which is the frustration that is below our migrants. This phenomenon is known to be a risk factor for the development of disorders. When it comes to geographical origin, you can see that our sample is relatively well spread out, and the most represented countries are Gambia, Romania, and Bangladesh. When you look at categorical diagnoses, you can see that there's an overwhelming majority of mood disorders, with psychosis representing only 26%, but it must be noted that the majority of these diagnoses are subcategorized and not otherwise specified because of the aforementioned extreme clinical variability of the presentations, which makes it really hard to categorize traditionally. Now I can finally show you some results. Let's start with the dropout. You can see that 75.8% of patients will come to follow up at least once, but almost the exact same amount of patients will have dropped out in 12 months, with a mean number of visits of 5.8. This highlights the extreme instability of the migrant population when it comes to follow-up. And if you looked at the data in relation to biological sex, you can see that males drop out exponentially more than females. This is a regression graph showing a positive correlation between PPRS total score and number of follow-ups, highlighting the fact that the more severe psychopathology is correlated with longer length of treatment. Then we compare the means of the dropout group versus the non-dropout group in each of the psychopathological dimensions. And after performing a t-test, we saw statistically significant data regarding the PPRS total score, the positive symptoms, and the disorganization dimensions.
Our bivariate analysis found statistically significant data almost everywhere, but once we ran everything through a multivariate logistic regression model to predict dropout at 12 months, only positive symptoms and sex were statistically significant predictors of dropout at 12 months. In particular, positive symptoms are protective against dropout, and male sex is a very strong risk factor. This study supports the use, whether it's retrospective or prospective, of the analysis of data to understand mental health. We can use this course on first visit to estimate length of treatment in patients. Higher BPRS score, female sex, and more positive symptoms lead either to lower dropout risk or to longer duration of treatment. In order to understand which of the two we're talking about, we have to tailor our clinical approach according to the patient's preference. For women, we have to understand whether there's gender-related protective, such as being more emotionally proficient and more willing to access mental health care, or if they need longer treatment. Therefore, service utilization should be investigated. In men, we know that there's gender or higher dropout risk. Therefore, in clinical approach from the first visit, dropout prevention should be implemented. In patients with positive symptoms, we should understand whether the presence of positive symptoms represents an indicator of poor prognosis, or in addition, if we're in front of a phenomenon that we call induced adherence, which is due to the fact that positive symptoms tend to significantly destructure the functioning of the person, and it's noticeable by the environment. Therefore, it's the environment that brings the patient to the hospital, a sort of a forced follow-up. It needs to be noted that if we don't investigate the risk, we are unable to discern between we need to further investigate the reasons for dropout because it's inevitably a risk factor for poor prognosis. Thank you for your time and your attention.
Thank you very much, Armando Muro. Are there questions by the committee, the Professor Berardelli, please.
This is a nice study, but I'm thinking that probably you may need to have also a control group of patients, non-migrants, just to see whether the correlation that you found are also observed.
Is the need of a control group of non-migrant people? I'm saying because there are people that are following from home. I mean, then maybe that they didn't hear you. Please.
Unfortunately, when it comes to the outpatient service for clients, it's not
working anymore, so we cannot further collect data to conduct a control study. But I think for the data that we have collected before, we already saw higher dropout of migrants compared to the general population.
Good afternoon. Thank you, President. Good afternoon to everybody. I want to take just it's for me a pleasure to introduce to you Giulia Laurea. She showed strong interest in cardiac surgery, despite my strong advice, and more than all, she likes very much pediatric cardiac surgery. That's why I want to thank Professor Brancaccio, who is not here, because under his supervision, she was able to make a very, very, very beautiful job and work on a very interesting field of pediatric cardiac surgery. And I want to leave the word to Julia so she will explain all the insights of this study. Thanks.
So, can you hear me? No. Okay, now better? Yes. Okay, thank you. Thank you, Professor Marulo, for the kind words, for the introduction. And as the professor said, today I will tell you something about mitral valve surgery in childhood. So, briefly, the mitral valve is a complex three-dimensional apparatus made of different structures that dynamically work together to efficiently open during diastole and close during systole, so to ensure unidirectional blood flow from the left atrium to the left ventricle. Proper valve function requires not only the integrity of any of these components, but also their coordinated interaction. Any valve level can be affected alone or more commonly together with other valve segments, leading to mitral valve dysfunction. Mitral valve disease in children is quite common, but fortunately, severe lesions requiring surgery represent just a minority of cases that, however, cannot be ignored. So during the last decade, the surgical approach to mitral valve dysfunction in childhood has significantly evolved. Despite the development of new surgical techniques, the two main approaches adopted in the settings that are mitral valve repair and mitral valve replacement can still be considered risky and challenging because of special features and needs of this population. Indeed, because of the age, the heart geometry is small, the structure is fragile, and more importantly, the growth potential needs to be maintained. So strong incentives exist to repair rather than replace, allowing for nitric valve and ventricular geometry preservation. However, because of a wide variety of diseases, this technique is considered scarcely reproducible, and actually one of the least reproducible techniques in cardiac surgery. Indeed, it's worth to mention that cardiac disease in children can be due to both congenital and acquired condition. The latter being mainly the consequences of endocarditis and rheumatic fever, while congenital disease includes a wide spectrum of malformation and a high associated rate of cardiac lesion. When repair is not possible, replacement is performed with all that entails. Because bioprostheses undergo early calcification in childhood, mechanical prostheses are often preferred, being available in smaller size and being more durable, albeit with important drawbacks, such as the need for lifelong anticoagulation, which is particularly difficult to manage in children, and importantly, the need for reoperation that, of course, will somatic growth of the child. So we must say that for both the approaches, the literature is quite varied about the outcomes. So this is why we performed this study. This was a retrospective analysis of patients that underwent primary valve surgery, both repair or replacement, at Bambino Gesù Children's Hospital of Rome from 1982 to April 2020. The aim of this study was to identify the freedom from transplant or death, survival by repair versus replacement, and freedom from reoperation. A total of 142 patients were included in the study. Of these, 72 were males. These patients were stratified according to age into 3 groups. So to have group 1, which included neonates and infants less than 1 year old, group 2, which included children from 1 to 5 years old, and group 3, which included children above 5 years of age. For each age group, these characteristics and demographics have also been analyzed. For example, here in the graph, you can see the different pathologies for the different groups. For instance, congenital dysplasia represented the great majority of cases in neonates and infants, while congenital dysplasia and acquired condition, namely rheumatic heart disease, were equally present in children above 5 years of age. Importantly, a total of 84 patients underwent primary repair, while 58 patients underwent primary replacement. About the result, this is the full representation of transplant-free survival for the entire, showing that
about the survival becomes stable, so the curve becomes flat, already after 5 years of follow-up. The same finding was also observed when survival was expected for age group. In this case, the survival for children above 5 years of age, that is the light green curve in the graph, I don't know if you can see well, appears to be slightly better than for the other groups. However, this finding was not found to be statistically significant. When analyzed according to the primary type of surgery performed, survival was quite surprising because in this case, the survival after replacement did not differ greatly from survival after repair, being 85% and 90% at 10 years respectively. However, when analyzed according to age group, it became evident how neonates and infants undergoing replacement had a worse survival with respect to the groups. And I'm referring to the yellow in the graph. Indeed, it's important to stress how demanding can be this type of surgery in this age population because of the small anatomy of the heart, structural fragility, and high degree of associated cardiac lesions. Finally, this is the curve analysis for freedom from operation for the entire cohort, showing that about half of the patients need to undergo again surgery after 10 years from primary surgery. Considerably, the freedom from operation was found to be significantly different among age group, being lower in neonates and infants already after the first year after surgery. The reasons behind this finding can again be found in the small anatomy of the patient and consequently in the small prosthetic size that can be initially implanted, and that will need for sure reoperation with the somatic group of the patient. We can conclude that mitral valve surgery in children can be performed with acceptable risk of mortality, especially in children above 5 years of age. Mortality among every age group, is higher in the first postoperative period, reaching a plateau already after 5 years from primary surgery. We were surprised to find that overall survival after replacement did not differ greatly from survival after repair in this series. However, repair should be considered the first therapeutic choice, even if the risk of reoperation is high, especially among neonates and infants. Indeed, survival from mitral valve replacement in the youngest is still poor, and every effort should be taken in place to repair rather than replace, and postpone as much as possible replacement in the youngest. Finally, I would like to add something, is the need for continued research on operative techniques and prognostic factors that can allow for a more refined patient stratification so that patients could be better addressed and face, when possible, a lower mortality risk. Thank you to all.
Thank you very much, Note Giulia. Are there not any questions noted by the professor, Professor Midulla, and then Professor Chiaretti?
Okay, thank you very much.
No.
If I understand well, you recruit patients during 14 years.
Yes.
My question is, but the
Surgical technique hasn't been changed during these 40 years. How can you compare patients that received surgery in 98 with patients that received surgery in 2020?
Indeed, the length of the research, of the analysis, was considered a limitation for the study because of the change in operative techniques. However, we found that the change was not that significant because the great innovation occurred quite earlier than the starting of this analysis. And most importantly, the surgical techniques are varied, as I said, but are quite stable because nothing more can be done in this setting, let's put it in this way. Oh yes, I agree with you that 38 years of length is quite enough, is maybe too much, but unfortunately, because of the rarity of this condition, we need to recruit many patients as possible, and it's possible only increasing the time length, let's say.
Okay, the next the candidate is Ben Shira de Ben David, Shira de Ben David present the thesis, the title is COVID-19 and multi-system inflammatory syndrome in children, the role of high mobility on the group box on the one. The supervisor of the thesis is Professor Fabio Di Midulla. Please, the professor, could you introduce briefly the candidate and the thesis?
Okay, good afternoon to everyone. We heard before about COVID-19 in children. Fortunately, in Italy and Europe, it has been a very mild disease. The only severe complication is MISC, and we heard about the clinical presentation of MISC. With her study, Shira tried to see which could be the role of this very important inflammatory mediator that is HMGBI in the pathogenesis of MISC, and if her study will be confirmed also in other study, we can probably consider this protein as a target for a specific therapy. Shira was very, she is a very smart student. We were very happy to have her with us during the last year.
Thank you, Professor, for the kind introduction, and good afternoon for all the members of the committee and for everyone who's watching us. Today, my study was based on the role of high mobility group BOX1, which is a pro-inflammatory mediator, in COVID-19 and multi-system inflammatory syndrome in children. First of all, COVID-19 is a respiratory illness associated with severe acute respiratory syndrome. Most of the patients usually refer to fever, sore throat, cough, dyspnea, and fatigue, and new loss of sense of smell and taste. Now, although most of the patients usually recover within a few weeks, others may experience post-COVID condition with long-lasting illness and multi-system inflammatory syndrome. Addressing specifically multi-system inflammatory syndrome in children, MISC was first reported in previously healthy children presented with Kawasaki disease-like features. MISC is diagnosed based on the case definition of the CDC. We have children and adolescents aged less than 21 with persistent fever, hyperinflammation, multi-system organ involvement, and no other possible diagnoses, and with the presence of either current or previous SARS-CoV-2 infection demonstrated in PCR or serology. Now, addressing the hyperinflammatory status in these patients with MISC COVID-19, HMGB1 can be has an important role in the mechanism behind inflammation. As you can see here, HMGB1 can release either passively from injured cells or actively from active immune cells. It will then bind different receptors on the cell surface and will induce the translocation of NF-κB that will result in the secretion of inflammatory cytokines, among them also HMGB1 itself. HMGB1 is also involved in different pathologies. It is associated with cardiovascular diseases, with coagulation and thrombus formation, and specifically speaking about Kawasaki disease, it was found to be highly expressed in children with coronary inflammation and dilation. HMGB1 was also reported recently in patients with the SARS-CoV-2 infection and severity. There are two studies that were reported in the literature in the adult population where HMGB1 was found to be highly and significantly increased in patients with severe COVID-19 and fatal complications. Due to its involvement in SARS-CoV-2, we decided to test HMGB1 also in MISC patients. So the aims were, first of all, to describe the clinical picture of MISC patients that were hospitalized in the pediatric department during the period of November and March, and to test and compare HMGB1 levels in MISC patients to that of COVID-19 and healthy children. We had 46 children in total, divided into 3 different groups. We had 5 patients who fulfilled misdiagnostic criteria, 20 children with history of SARS-CoV-2 infection. They were tested 1 month after recovery, and 21 healthy children without evidence of any other respiratory illness in the last 3 months. Importantly, 15 of these patients were enrolled in the pre-pandemic period, and 6 were siblings of patients affected by SARS-CoV-2. We tested agent GB1 using Western blot and the presence of anti-spike IgG using ELISA. Here you can see the result. So we had 5 children who fulfilled misdiagnostic criteria. They presented to us with a persistent fever with a median age of 8.36 years. They had a minimum 2 different organ system involvement. Some could have a respiratory distress or a normal chest X-ray. Some had a cardiac involvement with coronary dilation and inflammation. Others with acute gastrointestinal symptoms and also a mucocutaneous rash. Now, 4 out of 5 of our patients were treated with aspirin and a single administration of intravenous immunoglobulin. The last patient, number 5, was treated with high dose of steroid because her diagnosis was made only later on during her hospitalization. The laboratory result you can see here, the median level of agent GB1 was significantly high in both MIST group and COVID-19, which is interestingly, we can see that in patients in the group with COVID-19 illness, the level of agent GB1 was still higher also after 1 month after recovery. We did a comparison between the group, which we found a clinically significant increase of the level of agent GB1, comparing COVID-19 versus MISC and MISC versus control, and the much more significant difference between COVID-19 and control group, which is probably also due to the sample size. We had 2 patients of MISC at follow-up, where you can see that they had a marked decrease of agent GB1 after 50 and 62 days, where they had also a marked amelioration in the clinical picture and also presented with a normal echocardiography, which was previously presented with a coronary inflammation and dilation. Agent GB1 was correlated also to a coronary dilation in MISC patients. Here we did not find a significant difference, but still we found a slightly higher level in the patients with coronary dilation. We also correlated agent GB1 and the clinical feature in COVID-19 group without MISC. Also here we did not find any difference between symptomatic and asymptomatic, which is different from what is reported in adult group in the literature. We suppose that this difference is probably due to the population that is studied. This study is the first study to our knowledge to study agent GB1 in the pediatric population shortly after SARS-CoV-2 infection. Lastly, agent GB1 and anti-spike IgGs, we tried also to find any correlation between the two. We did not find any correlation between the 2 markers. Now, to conclude our study, the high level of agent GB1 protein that we did found in the serum of COVID-19 patients, again, in both symptomatic and asymptomatic, and in MISC patients, confirm its role in their pathogenesis and complication. And moreover, our result, the high level of agent GB1, suggested as a potential biomarker and also as a therapeutic target in patients who present with severe COVID-19 illness. Thank you very much.
Thank you very much, Sheila, and congratulations for your presentation. Are there any questions by the professor of the committee? Please.
Do you know whether this protein is specific of the disease or it can be found also in other inflammatory conditions or even in normal? I didn't get whether you can see normal subject as well.
Yeah, so previously the first
slide.
You can see here that HMGB1 is generally a pro-inflammatory protein that is secreted during the inflammation from either cells that are going apoptosis or from cells of the immune cells like macrophages, dendritic cells. So it was also reported HMGB1 as a specific biomarker for inflammation, and it was also found in a significant higher level in considering Kawasaki disease. So in patients that had Kawasaki disease and coronary inflammation, they did found a significantly high level of this marker. So first of all, in general, it is found in other different diseases, of course, because it is a pro-inflammatory molecule. But it is interesting to see this molecule in our population, in the MIS patients specifically, where you could see the significant high level that we found in comparison to the COVID-19 and control. Thank you very much.
So the next the candidate is Gregory Arthur Michael Horsfall. The title of the thesis of Gregory is clinical manifestation of SARS-CoV-2 and persisting symptoms in children. The supervisor again is Professor Midulla. Please, the Professor Midulla, introduce briefly the candidate.
A lot of COVID-19 infection in children. Greg is going to report the results of long COVID in children. We know that 20% of adults present symptoms of long COVID. He will present our results of a follow-up that we are doing in our clinic with patients that had COVID-19 infection. About Greg, it was very nice to have him with us, and I must say that I'm quite sorry that he's going to leave because he's an English-speaking person and he was going to translate and correct all our scientific paper. And so I don't know what we need another English-speaking student for the future. Thank you.
Thank you very much, Professor. That was quite unexpected, but thank you very much. It's been a pleasure to come to pediatrics, and I really appreciate the experience that you've given me. So thank you very much. And so to begin, so this was a study on the clinical manifestations of COVID-19 SARS-CoV-2 in the acute phase and also the persisting symptoms, which has been termed long COVID. So what we know so far about COVID in children is that infections are less frequent in children. Also, that the vast majority of children have either asymptomatic disease or mild disease. Severe infections, we've seen some, but they're relatively uncommon. MISC, for example, it's quite uncommon. And for the severe diseases, we've also seen it associated with certain comorbidities, like chronic lung diseases, like congenital heart disease, and also cancer. So moving on to what can happen after COVID disease, we have the post-inflammatory syndromes. So we've already heard today about MISC and Kawasaki disease, but we also have this concept long COVID. So what is long COVID? So it's been defined as the signs and symptoms that continue or develop 4 weeks after acute COVID-19 infection. And so this has approximately been seen in 10% of adults, this is. So symptoms, we actually have a wide spectrum of symptoms. This is just some of the most common. So we have cough, we have dyspnea, headache, but we really do emphasize that there are lots of different symptoms that people are manifesting after COVID infection. So this was the aim of our study. What we wanted to do was see if long COVID is present in children. So we were evaluating acute COVID-19 symptoms and also these persisting symptoms, long COVID symptoms. We also wanted to see if there were any potential risk factors for further study. So what happened was children and their parents or guardians were invited for a clinical follow-up at Policlinico. Umberto Primo, and we are looking today at the first 200 of these children that came. So a prerequisite for inclusion in the study was that they were confirmed as a positive case with a PCR swab test. Okay, so this was a little bit on the demographics. So we wanted to take lots of information to see if there were any risk factors like prematurity, for example. And then on the right, we see the age distribution. So this was the different age groups that attended the follow-up. Now over to the results. So what we saw was that from the 200 children, 87% were symptomatic, 13% were asymptomatic. And so this roughly corresponds to what we've seen in the literature so far, but also we're only taking into account the children that attended the follow-up. There's many reasons why they might not attend the follow-up. And also children that say they're asymptomatic, they might just not know, especially the young children. And so what we saw in these 200 children, we saw 2 hospitalizations, one of which was a MISC. So not many severe infections in these children. So now onto the acute phase symptoms. So we saw fever, headache, asthenia, which is similar to fatigue. They're often used interchangeably as the most common symptoms. And then we also saw a predominance of neurological symptoms. So we included in that headache, anosmia, ageusia, and we really saw a lot of neurological symptoms in children, which hadn't really previously been seen in previous studies. And then we also saw a pattern of increasing reporting of symptoms in older children. What we did is we divided the children into 4 different age groups, as you can see, 0 to 4 years, 5 to 9 years, and so on. And what we saw is, as you went up, as the children got older, they were reporting more symptoms, or not more symptoms, but more frequently, I should say. We also saw something quite interesting. We saw that the BMI was different in the symptomatic group of children and then the asymptomatic group of children. So children with an increased BMI, as you can see there, were reporting symptoms more frequently. So that could potentially be a risk factor, but that would need to be assessed in further study, but that was statistically significant, as you can see. Now onto the persisting symptoms, the long COVID symptoms. So you can see that 28% of our cohort reported persisting symptoms after 1 month. And the most common symptom was asthenia, I should say. We also saw headache as well, very frequently. You can also see that there were many symptoms in that other bar, because we really had a huge list of symptoms that the children were reporting. Just to give you a few examples: anxiety, depression, sleep disturbances. We also saw chest pain, abdominal pain, a huge number of symptoms. So now what we wanted to do was assess the potential risk factors for these persisting symptoms. So what we did is we took a risk factor like having dyspnea or respiratory difficulty in the acute phase, and we looked at what frequency of these children are manifesting the persisting symptoms if they have dyspnea in the acute phase, or alternatively, if they don't. And what we saw is if you have dyspnea in the acute phase, you are potentially more likely to report long COVID symptoms, to report persisting symptoms. So this could be a potential risk factor. All of these were statistically significant. So we had dyspnea, ageusia, anosmia, pharyngitis, myalgia. Also, if you had respiratory symptoms in the acute phase, and then if you had 5 or more symptoms in the acute phase. This has previously been reported in adults to be a risk factor for long COVID disease. Other than that, we again saw a similar pattern for older children. Older children manifested long COVID symptoms more frequently as you went up the age groups. And then to more potential risk factors was smoke and BMI. So first of all, the smoke, we saw a significant difference if they had a previous exposure to smoke in the household. So we thought about whether the parent smoked or whether a sibling smoked. We potentially think that both the smoke exposure and the BMI associate with a lower socioeconomic status, and this might play a role in reporting persisting symptoms. So our conclusions are that symptoms in children are mild and they are infrequently severe, as we already knew before, and as we've seen in our study as well. Also, we saw a predominance in the persisting symptoms, long COVID, of neuropsychological symptoms. So this could actually, not actually only be to due to COVID-19, but it could also be due to the pandemic, the media coverage of COVID-19, or even deconditioning as well, we have to take into account. So there could be many reasons why these children are manifesting these symptoms, and further study needs to focus on which children need to be followed up more closely, perhaps. We also conclude that some risk factors, like the BMI, like the smoke exposure, like manifesting more symptoms, like 5 or more symptoms, may influence the acute phase and the long COVID symptoms. So thank you very much.
Thank you very much, Gregory. And I wanted to ask if there are questions by the committee, by the professors. I have a specific question, Gregory. I mean, you told about smoke exposure as a risk factor for long COVID. How was assessed the exposure to smokers? Maybe that parents were asked if they were smokers or not. There were an attempt to quantify the level of passive smoking.
We didn't actually, but that would be something very interesting to do, and we could do that in many areas in our study. But what we did is we asked, do any of the parents smoke, or anyone in the house, do they smoke? And if it was positive, then we would put smoke exposure, and that was as far as we went. But of course, maybe further study should look into that. We suspect that smoking doesn't really correlate, doesn't really associate with the COVID-19 disease specifically, but we think that they may just would be more likely to report the symptoms, maybe difficulty at home and so on, like I was saying, the lower socioeconomic status.
Professor Medulla, I have to ask you if you are formally satisfied by the candidate. The Professor Medulla, your supervisor, is satisfied. So, Gregory, thank you very much. So, the next candidate is Valeria De Salmeo. Valeria De Salmeo is presenting the thesis. The title is Impact of COVID-19 Pandemic on the Cardiac Surgery Department in Policlinico Umberto I. Your supervisor is Professor Fabio De Miraldi. Please, the professor, if you want to introduce briefly the candidate and the thesis. Thank you very much.
Thank you very much, Mr. President. Thank you, everybody, and good afternoon. COVID-19 pandemic was terrible for COVID patients, but it affected also other patients, especially in cardiac surgery, because cardiac surgery needs intensive care, and they were occupied by COVID patients. And so Valeria analyzed what happened in our cardiac surgery center, and we compared what happened with what happened over the world. Valeria?
So, thank you, Professor, for the introduction. So the aim of our study has been to assess how COVID-19 pandemic has been coped with in the cardiac surgery department in Policlinico Umberto I. So in order to define the impact on our department, the approach to the same situation in other realities, specifically other countries around the world and other hospitals in Italy, has been analyzed. So in all the selected countries, some kind of lockdown has been established
And with only 2 exceptions, resource shortage was faced. Specifically, there was a shortage of personal protective equipment, ICU beds, and ventilators. With some countries had to adjust their entire healthcare system in order to face the situation. For example, Australia and Trinidad and Tobago made agreements with private sector in order to have sufficient supplies, while the other countries mainly employed cuts and redistributions. The cardiac surgical activity was greatly reduced, and especially in the first part of the pandemic, it was restricted to emergency and urgent surgeries. Of course, this had a great impact also on the waiting list management and composition. So here are the aspects addressed in the published Italian studies. Speaking about the general organization, many regions implemented the hub and spoke model to adequately redistribute the increased workload. Screening and safety measures were implemented in order to avoid the onset of hospital outbreaks. Resources were scarce, so changes in the cardiac surgical activity were mandatory, affecting both daily hospital activity and waiting list management. The only national survey conducted by Rubino et al. Reports that there has been a median reduction in the cardiac surgery case volume by 53.5%. There has been a change in the referral patterns with an increase in the percentage of emergency and urgent surgery. These data are in contrast with what we found in our case series, but this difference can be explained by the fact that patients with a higher priority were primarily referred to hub centers. So there is a difference in the type of surgery performed during lockdown 2020 and 2019 due to an increase in the referral of patients with acute coronary or aortic syndrome, and consequently an increase in the percentage of coronary artery bypass graft procedure and either endovascular or open aortic procedures. So in the analysis of our department experience, the primary endpoint of the study was the number of patients treated in 2020, that were 160, with respect to the ones treated in 2019, that were 324, corresponding to a 49.4 reduction in the surgical activity. Here is distribution of patients treated in 2020. We can see there are 2 minima, one during the lockdown months and the second one during the winter months and continuing then in 2021. Here are the details about different type of surgeries performed. The most important information is that in 2020, the most performed surgery was coronary artery bypass graft, while in 2019, it actually was invasive valvular replacement. The general features of patients in the 2 groups are mostly homogeneous. The only exceptions are a decreased left ventricular ejection fraction and an increased error score 2. Those are not absolute indices, but they seem to support the hypothesis that patients arrived at the moment of surgery with the worst clinical baseline. So mortality was the same in the 2 groups, but there was an increased complication rate, postoperative complication rate. Specifically, we found a significant increase in the percentage of patients with respiratory failure, acute kidney injury treated either with or without dialysis, and either pacemaker or intra-aortic balloon pump implantation. Length of stay was significantly longer during 2020. This can be due to the fact that there was an increased complication rate. or by the fact that patient had to be preferentially fully healthy at the moment of discharge in order to be sent home directly rather than to a rehab center according to the COVID-19 mitigation strategies. So as I briefly mentioned, during 2020, we've seen very much decreased surgical activity. Different type of surgeries performed, an increased pre-surgical risk, and complication rate. So even though our results are comparable to the findings in other centers, during the months of lockdown, the negative impact in our department have been prolonged. So more recent data coming from other centers might be useful to have a more reliable comparison. But anyway, we can confirm that the impact on our department has been severe and long-lasting. Thank you.
Thank you very much, Valeria. I appreciate very much the approach, because you start from the world context, and then you go to the country, the context, and then to the local context. I appreciate very much this approach. Okay, are there any questions? Professor Mirulla, please. Professor Mirulla, I'm sorry. You have to speak.
The death rate of the patient in periods.
Death rate. Yes. No.
Normally and during the lockdown.
Unfortunately, we weren't able to have a reliable number about this because patients on the waiting list during 2020 were actually referred elsewhere. So we lost the information about those patients. So it was pointless to have a comparison on that. It was very difficult to have.
Okay, the professor Mirulla, I appreciate very much the fact that you do not respond to the question because you thought and said that the task is of the candidate because you are ready the graduate in medicine to result to me. Okay, are you satisfied by the candidate?
Extremely satisfied about the candidate. I'm not satisfied about cardiac surgery because we are not back to normal, even though we are nearly at the end of the emergency.
But this is a situation, seen in all disciplines of medicine. Okay, so Valeria, thank you very much. The next candidate is Alessandro De Maio. Alessandro De Maio is presenting the thesis, the title is Magnetic Resonance Guided Focus on Ultrasound Surgery versus external beam radiation therapy in patients with painful bone metastasis phase 2 non-randomized clinical trial. The supervisor of the thesis is Professor Alessandro Napoli, and please, the Professor Napoli introduce briefly the thesis and the candidate. Thank you.
Good afternoon, everybody. It's a pleasure for me to introduce Alessandro De Maio, who was involved in the conduction study at the radiology unit, specifically the interventional radiology, where we have since 2010 a new machine called magnetic resonance guided focus ultrasound, which is a totally non-invasive machine that creates a thermoablation deep into the body. Now, Alessandro was involved in a phase 2 trial comparing this technique against the standard, which is the external beam radiation therapy for bone metastasis. So please, Alessandro.
So good afternoon, everyone. I would like to thank Professor Napoli for his kind words and everyone who's here watching us today. So as you already said from the title, I'll just go on then. Okay, as some background regarding bone metastasis, it is currently estimated that 330,000 patients in the US alone are diagnosed with a bone metastatic disorder. These 64% of the patient will experience pain, particularly severe, and also being exposed to a number of skeletal related events. These are especially fractures as well as spinal cord compression, typically requiring image radiotherapy. A pain palliation treatment line typically for such patients are especially supportive at start, so following the WHO ladder with steroids up to then opioids, but then requiring radiotherapy, surgery, and with the newly approved in US, Europe, Canada, and Asia, also focused ultrasound. So, but what is magnetic resonance guided focused ultrasound? First of all, is a non-invasive tool able to cause coagulative necrosis, and while following with the feedback of the magnetic resonance imaging. And here in this short clip, you can have an idea of how it works. And with the ultrasound system, we actually can burn in a controlled fashion the tumor by increasing the with sonication the temperature locally with a spatial resolution of 1 cubic millimeter while delivering ultrasound energy. And this is a case of a 42-year-old woman who was diagnosed with a stage 4 breast cancer. And here we see the iliac bone, and here this is the lesion that we see. This is her metastasis, and this is immediately before treatment and 2 months after follow-up after focused ultrasound treatment. And we can see how not only the pain was gone, but also we can see a de novo mineralization. Instead, in figure C and D, we can see immediately before and after the treatment, how with the contrast-enhanced MRI images, we can see these spots in figure D, black spots, where the actual coagulative necrosis was achieved. The objective of our study was to compare in terms of safety and efficacy, the standard of care, external beam radiation therapy versus the focused ultrasound, which is the alternative. And from the literature, we know that focused ultrasound is able to provide pain improvement over 1 to 3 days after one session, delivering ultrasound energy, while the radiation therapy is able to provide pain improvement over 1 to 4 weeks after 1 to 4 sessions while delivering radiation energy. The test measurements that we used were primarily for bone pain visual analog scale, while for the bone metastasis patients, regarding especially tests like brief pain inventory, the C15 palliative care, and the bone metastasis 22. So the design of our study was a multi-center open-label phase 2 clinical trial with a 12-month follow-up program. Inclusion criteria were age above 18 years with a VAS for bone pain above 4, and the treatment area had to be smaller than 100 square centimeters, as well as more than 1 centimeter away from the skin, and also no previous radiotherapy treatment on that targeted lesion. Exclusion criteria were instead a poor life expectancy, a poor performance status as measured on the Karnofsky score, and also typical contraindication to the contrast-enhanced magnetic resonance procedure. So our primary endpoint was pain improvement for patients, while secondarily we wanted to assess complete pain remission, partial pain remission, as well as quality of life measures and overall survival, as we thought to be particularly interesting for this kind of patients. Regarding the results, 229 patients were assessed at the beginning, and 198 underwent instead treatment assignment, 100 underwent magnetic resonance guided focused ultrasound, and 98 radiotherapy. Respectively, 38 and 23 completed the follow-up program. Here we can see in the summary table how there were no differences in the population in terms of age, sex distribution, as well as distribution of the sites of painful bone lesions, and also the baseline pain assessment. Moving on towards the pain improvement results, here we can see here in the graph in blue how the MRG FAS is highlighted. So the focused ultrasound group is highlighted in blue, and in red the radiotherapy group. And we can see how already after 1 month, the focused ultrasound group patients already experienced a way lower bone pain compared to radiotherapy, and this was statistically significant at all time points except for 6 months, while the radiation therapy group experienced instead a relapse of pain between 6 and 12 months. Hazard ratio for pain improvement was 2.23 in favor of MRG FAS, and similar results were achieved with VAS and BPI, while not for the other 2 tests, and this allowed us to continue with subcategorical analysis. And here is an example how complete remission In blue, again, we can see an example of 55 patients at 12 months in the focused ultrasound group were completely free of pain, while only 22% of the patients in the radiotherapy group were free of pain. And also here on the right, we can see how the sub-items of the C15 palliative care tests were used. And also these are typically related to the radiation side effects, like physical dysfunction, dyspnea, nausea and vomiting, loss of appetite. And these particularly lower scores in such tests, we believe that it led to a higher quality of life perceived in the focused ultrasound group. Regarding the survival, also, it was statistically significant when measured with the log rank test, how with an overall time of survival with a mean of 7 months for survival of the focused ultrasound group versus 5.2 months in the radiotherapy group. And hazard ratio for survival was 1.38 in favor of MRG FUS. Regarding to the conclusions, so as we know from the literature, a magnetic resonance guided focused ultrasound is a safe, efficient, and a cost-effective alternative for pain palliation in such patients. Moreover, we could confirm how it confers significant advantages over radiotherapy for pain palliation in terms of pain remission, how fast it is achieved, and also no radiation-related side effects since we use ultrasound. The quality of life measure seems to be higher in such patients when treated with focused ultrasound and a prolonged survival time. Where do we go from here? So first of all, to confirm our studies and our finding, considering all the limitations of our study design, first of all, we need a randomized phase 3 clinical trial. And also a question would be, can we go beyond pain palliation? So can we go beyond treating pain and even treating the metastasis itself, allowing for a tumor control, as we know from other literature studies? And also, if we can confirm all such claims, we can even hope for a more widespread application of such technology. Thank you all for having me today.
Thank you very much, Alessandro. Are there not any questions by the commission, by the professors? I have a question because you told that in your thesis, your presentation, that this is a phase 2 trial. I agree with you, but it seems to me that you are more close to a phase 3 trial than a phase 2 trial. And at the end, you said that some large randomized control trials that are needed. It seems to me that from an ethical reason, it is quite difficult to randomize the people to this technique and to the old technique, because it seems to me that the advantages of the new technique is quite evident. What do you think about that?
First of all, the limitations of our study are mainly this is a multi-center study, and so the focused ultrasound system is available for example here in Rome and a few other places all over Italy. So so the distance for the patient, this was also an important consideration for the patient. So also it is even more difficult to randomize patients. Yeah. But nevertheless, it is important because, for example, this study was carried out with a joint decision between the teams of physicians, oncologists, and therapists, as well as the patient is involved. So on one side, we can even have the limitation of the hope of the patients for a better and newer technology, or the opposite for a well-consolidated technology. So really can be a further step that's going on. Thank you.
The next candidate is Agar Zeltzer. The title of the thesis of Agar Zeltzer is HPV infection, the multidisciplinary approach. but this is actually an observational study. The supervisor of the thesis is Professor Innocenzo De Palaia. Please, Professor De Palaia, could you introduce briefly the candidate and the thesis?
Everybody, and afternoon. I added for because it was really difficult to perform this study pandemic year. To the work that our output were closed for 11 months, and the second was of decision. And she will present preliminary results of this study, which is and by and continue please add your results. Okay, thank you. Thank you, Professor, for the kind introduction. So, as Professor Palaia mentioned, this study is about HPV infection in a multidisciplinary approach. So, a little bit of background about HPV or human papillomavirus. HPV is the most common sexually transmitted disease worldwide. It is estimated that around 6 million new infections occur in a year, and moreover, more than 80% of women are estimated to acquire the infection by the time they are 50 years old. Human HPV, human papillomavirus, has a wide range of subgroups. Specifically, the alpha papillomavirus is the most important one because it has been associated with human infection, and some types in this alpha papillomavirus has been associated with the formation of human disease. As we can see, HPV is associated with a wide array of disease in humans. Specifically, if we start in gynecology, HPV was strongly associated with cervical cancer. If we look in the oral cavity, HPV has been associated with both benign, such as common wart, and malignant disease, such as oropharyngeal squamous cell carcinoma, in which HPV-associated oropharyngeal squamous cell carcinoma is increased in recent years. Moreover, in the anorectal area, HPV can again cause benign condyloma pulmonaris or malignant disease, such as anal cancer. So, past research have tried to evaluate the risk of women with cervical infection to acquire an extra gynecological infection, extra gynecological HPV infection, but the results and the data that we have about this population and this correlation between infection is still very much sparse. So our aim of this study is to evaluate whether a woman with a cervical HPV infection has a higher risk of acquiring an HPV infection in an extra gynecological area, and to understand the correlation between these infections. So our study, in the gynecology unit, we enrolled patients who were positive for cervical abnormalities which are related to HPV. These patients were then studied and sent to different units in order to evaluate clinically and laboratory infection of HPV. Specifically, in the gynecology unit, our patient went through a pap smear, a colposcopy, and an HPV test. In the proctologist unit, our patient went through a thorough examination of the area, a rectal digital examination, an anal smear, and an HPV test. In the otolaryngology unit, our patient went through a laryngoscopy to evaluate the area and to assess the presence of lesion. And in the oral cavity unit, an orthodontist performed a full examination of the oral cavity to assess lesions. Another part of our examination and of our study is to evaluate our patients' partners, male partners, to evaluate the presence of infection. The male partner went through a penoscopy and an HPV test, again, to assess the presence of an HPV infection. After the clinical evaluation, samples were sent to virologist laboratory where then DNA was extracted with a specific HPV kit, and then further evaluated by PCR in order to type the type of HPV. So from December 2020 to 2021, we enrolled 20 patients to our study. The median age of our patient is 44.3. Most of our patients, so more than 50%, were postmenopausal. 80% of them have declared to have a steady partner. And we also asked our patient regarding their sexual habits, specifically oral and anal sex. To these questions, more than 50% of our patients had agreed to answer. So if we look at the clinical results, we can see that 100% of our patients, so 20 patients, were positive in the pap smear. The grades of lesions were variable. In the proctology unit, 12 out of 20 of our patients were positive to lesions in the anal area that are related to HPV. In the laryngoscopy unit, 4 patients were positive to lesions. And in the oral cavity, 1 patient was positive for gingival papilloma. So when we look at our results, we had who presented with infection in multiple areas. Specifically, 4 out of our 20 patients, which is 20%, were positive in the 3 anatomical areas for lesions that are associated with HPV. Our laboratory results, specifically in the gynecology unit, presented that 12 out of 20 of our patients had infection with a high-risk HPV type. Specifically, 7 out of those 12 had infection with HPV 16. We are still awaiting for most of the results from most of our laboratory results from the different units. In the partner evaluation, so among the 20 patients that we had, 16 of them declared to have a steady partner. Among them, 9 of them agreed to participate in the study. Again, we are still waiting for most of the results, but for now we can see that 2 partners were found negative. So for conclusion, like Professor Palaya said, this project is a big project that is granted by Sapienza University, and the multidisciplinary team is applying for a PDTI in Policlinico Umberto Primo. What we learned from this preliminary result is that from the 20 patients that we had, 65% of them presented with HPV-associated lesion, which is extra-gynecological. Specifically, 60% of our patients were positive for lesions in the anal anatomical area. Now, these results can be associated with the anatomical proximity between the cervix and anal region, and can also be attributed to sexual behaviors. We believe that further evaluation is needed to be done in order to conclude the risk of this population of having multiple location infection, and overall, this study eventually can lead to a new scientific program and evaluate the needs for screening for these population of women that potentially can lower the burden of HPV-related neoplasia. Thank you.
Okay, thank you. Thank you very much. Agar Zelzer, thank you very much. Are there any questions by the commission? Please, the Professor Chiaretti, but you have to speak at the microphone. Thank you very much.
One question. For the partners, the few ones who are willing to participate, are you planning to do exactly the same screening? Okay.
Who is the Professor Palaya? The Professor Palaya, are you satisfied formally by the work of the candidate? Okay, so your supervisor is satisfied. Thank you very much, Agar. Thank you. Thank you. So it's the time of the next candidate. The next candidate is Yosina Raikal John, And the thesis of Yosin is percutaneous vertebral augmentation in the treatment of osteoporotic thoracolumbar fractures, a comparison between the vesselplasty and spine jack. The supervisor of the thesis is Professor De Gumina. Please, the professor, could you introduce briefly the candidate and the thesis? Thank you.
Thank you. It is a pleasure to present you the next candidate. She performed a very nice, very important job, a great job comparing the results of two different techniques that we use for the treatment of a thoracolumbar lumbar spine fractures. You know that these fractures are very important social and medical problem in terms of pain and disability. So she evaluated the results of these two different techniques, comparing the capability to correct the deformity and the ability to reduce, decrease the pain. So please show your results and wish you all the best for your career.
Okay, good evening, everyone. I think it's time. So thank you, Professor, for the kind words. So I think it's just okay. So our research study was basically on percutaneous vertebral augmentation in the treatment of osteoporotic thoracolumbar fractures, but with the primary focus on comparing the two vertebral augmentation techniques, vesselplasty and spine jack. So a brief recap on the anatomy of the thoracolumbar spine. So the thoracic spine is naturally kyphotic, while the natural alignment of the lumbar spine is lordosis. And the thoracolumbar junction is a flexible transition zone, which is vulnerable to damage because of the transfer of the kinetic energy. And also the kyphotic posture results in axial forces acting in the anterior portion of the vertebral body. And when the strength of this, the ventral vertebral body is exceeded, we have vertebral compression fractures. So most patients do not experience any symptoms, which results in delayed diagnosis, while some patients do experience significant pain, which requires medical attention. And the subsequent fracture risk following the first fracture is can increase up to 5-fold. And the risk of mortality increases with these fractures, and along with morbidities, including chronic back pain, becoming dependent on others, and restricted pulmonary disease, as well as other economic adverse effects. And we also have progressive spine kyphosis associated with it, which results in shift in the individual's weight, and there's a higher load in the anterior column, which again results in more fractures, so it's like a vicious cycle. And the general risk factors include advanced age, as well as decreased bone mineral density, which explains why postmenopausal women may be at higher risk. So when it comes to guidelines for the treatment of osteoporotic vertebral compression fractures, the standard primary treatment is conservative treatment, which include bed rest or preventive drugs for DVT, NSAIDs, as well as braces for when they're erect, so they can wear braces. And alternatively, we may also consider vertebral augmentation procedures, including, in particular, percutaneous vertebroplasty and balloon kyphoplasty in patients who do not respond to conservative treatment after 3 to 4 weeks. There are various guidelines, various different recommendations, but there's no strict algorithm that we can follow, so we have to improvise. And in a few words on different vertebral augmentation techniques that we normally use. So we have vertebroplasty, which involves high pressure injection of the polymethyl methacrylate cement into the fractured vertebral body. While with the first generation balloon kyphoplasty, there's an addition of a cavity, which is created with a balloon, which is inflated, and followed by which we inject a cement at a lower pressure, unlike vertebroplasty. And the second generation kyphoplasty technique is the vesselplasty, which uses mesh cage, and this actually acts as a receptacle, so it sort of contains the cement, preventing it from being extra osseous, but also it can expand, so it can actually adjust the height as well, just but a bit better than the balloon kyphoplasty. And the spine jack is a 3rd generation kyphoplasty technique, and it uses a metal stent, and it has a central screw and cranial and caudal deployable plates, which is expanded to achieve the optimal height, followed by which we gradually introduce the cement. And so in our study, we compared the 2 previously mentioned techniques, and we only included patients with single level fractures at the level of thoracolumbar junction, and only acute fractures, so around 1 to 4 weeks old, and based on anamnesis. The exclusion criteria included, so we excluded any patient with traumatic burst fractures, or if they had any sort of neurologic involvement. And based on this criteria, we were able to select 80 patients, of which 57 were females and 23 males. And the table shows all the number of patients involved by the vertebral level fracture, as well as the surgical management used. And so to compare these 2 techniques, we used firstly the mean reduction in the vertebral deformity by using the sagittal index. So we basically draw a line along the superior end plate of the fractured vertebra and also the inferior end plate of the vertebra, and the angle formed is the sagittal index. And the clinical variables were measured using the oscillatory disability index, which looks at the impact of the lower back pain on the quality of life, while the visual analog scale assesses the pain intensity. That's a case of vesoplasty, and then a case of the spine jack. So when it comes to results, I think the main takeaway is that the reduction of the vertebral deformity at the first follow-up, when we compare the 2 techniques, was significant. So it's actually in favor of spine jack. But even though this is true, when we look at the mean of VAS score and the ODI at the first follow-up for spine jack, there's no clinically comparable improvement. So this is the issue. However, we were able to see that there was a statistically significant decrease in the mean VAS pain score and ODI after the first and the second follow-up with both techniques when compared with the mean baseline scores. So a few words on the general discussion in literature on the different vertebral techniques, augmentation techniques. So we have vesoplasty, which was developed to gain more control of the volume of the cavity of the filler, and also avoid any sort of cement leakage, and also achieve optimal height. And with spine jack, it applies force in a cranial direction, unlike balloon kyphoplasty. So it again helps to achieve a better height correction. And also studies have demonstrated that a spine jack actually results in better vertebral deformity correction when compared to the either percutaneous vertebroplasty or balloon kyphoplasty. And they've also the studies have also said that the procedure is safe. And extravasation of the bone cement is one of the important complications associated with any of the vertebral augmentation techniques. And 9 to 72%, it's sort of range for vertebroplasty, and for 7 to 59% is the range for balloon kyphoplasty across literature. But most of them tend to be less relevant clinically. But in our study, the complications were minimal to absent. So there were 2 cases of cement leakage in the vesoplasty group. So to conclude, so our work aimed to highlight the immediate, so the short-term clinical and radiographic effects of cementation. And when we noticed that both techniques actually resulted in alleviation of pain, as well as enhancing the functional outcomes. And both are safe, and both resulted in remarkably lower incidence of perioperative complications when evaluated against data in literature on vertebroplasty. And also, but even though both techniques are both techniques resulted in better correction. Spine jack is preferred because of the fact that VP showed some limitations in fractures after 20 days. So in general, if we're going to opt for a cementation technique, when the conservative treatment fails, it would be better to choose a spine jack. And that's all. Thank you for listening.
Thank you very much, Diosina. There are questions by the professor. Please, the Professor Midulla. Please, go to the microphone.
Thank you very much.
Complication of this technique. And I've seen that your oldest patient was 82. Because this is the case, or because it's not recommended in older patients, like 90 years old or 83?
I think because it's a very advanced, more technical technique. I mean, it also depends. It basically, I don't think we had an age restriction of any sort. It was just that these patients happen to have these complications, the fractures at the time. And also, even this study actually took a long time. It's actually done across 9 years. So it was basically, there were no age restrictions. It was just happened to be that these patients were the ones that had clinic.
Professor Gumina, I have to ask you if you are formally satisfied by the work of the candidate. Sono di Diosina, the Professor Gumina, your supervisor, is satisfied. So thank you very much. Now it's the time of the next candidate. The next candidate is Cristina Angelotto. The title of the thesis of Cristina Angelotto is the mutual benefits between attitudes and formal education in robotics. Empirical evidence from medical students. The supervisor of the thesis is Professor Fabrizio Consorti. Thank you very much, Fabrizio. Please introduce briefly the candidate.
Application of robotics in medicine.
The last word we get is support for social, which is due to the healthcare of board and field. Many of us have the idea of robots coming from the science fiction movies, so since 2 years I offer an elective course of medical robotics students.
Designed in cooperation with Professor Vitelli, which is the responsible of the laboratory of robotics of Sapienza. And I wondered which was the idea and the attitude that my students had of robots. So Cristina will report on a pre-post prospective study we did with the cohort of students attending the elective this year.
Professor, good afternoon. I don't want this to run out of time, so I'll go straight to the core of this work. So the purpose of the research is focused on informing on medical robotics. We know the perspective of doctors and of patients, and now we are adding a third dimension perspective of medical students. Also, is focusing on assessing how education and attitude may interact and mutually benefit from each other, and leading to identify any potential barrier and what prevents robotics from its development in the medical field, starting from the assumption that both education and attitude are two important drivers for robotics to develop in the medical field. So we can see this relation as a cycle, since the higher educations, the higher the attitude, and therefore the expectations toward robotics that improve the quality of life. And if expectations are more positive will be the attitude that increase the research and therefore the learning curve. Robotics has grown exponentially over time, as Professor said, since 40 years old, and this exponential development of robotics that was established itself in medicine range from surgery with the Da Vinci robot system that overcomes limitations associated with laparoscopic treatment, adding minimally invasive surgery, to exoskeletons that open a new path in the treatment of permanent and temporary disabilities, to robot system adopted for the treatment of these disorders. And last but not least is the medical students training, Pediatric World. Pediatric World is the most advanced pediatric 5-year-old simulator. It is a form of artificial intelligence that gives to doctors the ability to practice under pressure in an unknown environment by simulating a real life situation. So it guarantees to doctors to dominate and to manage the unexpected and the emotions. But despite this exponential development, we can't compare robotics up to now only to the tip of an iceberg. Why? Because there is underwater world that we don't know, since we didn't exploit all the potentials, all the benefits of robotics. Since the robotics require doctors to improve their competency in order to suggest the most effective techniques. Also, patients have given their contribute with their feedback to improve the performances that over time robotics becomes more humanized. And also, forced research studies only focus also on medical students, gives results that are consistent with the findings that preference and experience, the environment, may impact on medical education. So one of the key to unlock these potential, these benefits, is to add robotics in medical education. So also giving an indirect benefit to hospital and university, showing that despite these initially high cost, we have those potential barrier. We have an increasing long-term benefits in the future social benefits that are exponentials. So this study, starting from the evaluation of the attitude of medical education that has cognitive, affective, and behavioral component, as well as bipolarity and responsiveness to stimulus, aims at providing how education and attitude may interact and mutually benefit from each other. And it is based on a survey submitted to medical students of the 6th year, before and after attending an online course provided on Moodle, consisted of 5 weeks asynchronous online course, and ended with a synchronous online serious game in which the students were divided in team, acting as an advisory board of a general hospital. So the analysis of this study wants to explore the cognitive component using the knowledge test consisted of 32 multiple choice questions divided into 3 assessments before starting the course, and in a post assessment, including the middle course and final course assessment. Also, wants to explore the affective component, the emotional attitude, using the PANAS test with 2 questionnaires, one provided before, the other after attending the course, and each questionnaire was consisted of 20 adjectives, 10 for negative and 10 for positive affective scales. And descriptive statistics are reported as means and standard deviations, and we can see an improvement of the post-interventional knowledge test with a mean knowledge score that range from 23 to 41%. But more interesting is the PANAS test results. I want to focus on the positive emotional attitude that is represented by the two columns. And we can see how this emotional attitude, the positive, is pretty much stable between the pre and post positive levels, reporting a high score even before starting the course. And this positive emotional attitude in medical students confirms how education's impact on attitude. The expectations of medical students was positive even because towards robotics. So since expectations of medical students were positive even before starting the knowledge test, we expect medical students to be more involved in this sector, and this may help future doctors to go beyond those barrier of conventional theory. So these relations of these two drivers, education and attitude, compared to an Hegelian spiral, since the concept is always the same, but at a higher level of human error. And since the result shows that after we have established the benefit and potential of robotics where no one ever wants to come back, let me leave with an open question: why not including robotics in medical education? We should, it's only the beginning. We should have to go on. Thank you. Thank you.
Okay, so the next the candidate is Eugenio Pepoli. I'm sorry, Eugenio Pepoli. Eugenio De Pepoli is presenting a thesis. The title is Association between the type 2 diabetes mellitus and thyroid cancer, a case series. The supervisor again is Professor Fabrizio De Consorti. Please, Fabrizio, introduce briefly the candidate. Thank you.
Diabetes, especially over 50. The age of 50. It is known to come with inflammatory environment, which uses or increases the likelihood of development of other diseases like cancer. So we already knew that there is an association between diabetes and different types of tumors. But it's still not well characterized as to subgroups. So the goal of this retrospective studies on a case series is to inquire if a group of patients operated with thyroid cancer had a higher prevalence not only of diabetes but also of intolerance to fast glucose. Please, Eugenio.
Thanks very much to Professor Consorti. Thanks to the Commission and the President, Professor Villari. I start with some epidemiology. Thyroid cancer is the most frequent endocrine neoplasm, about 90% of the cases, and accounts for 3.8% of all neoplasms. In Italy, about 16,000 new cases of thyroid cancer are diagnosed per year. At the same time, sedentary lifestyle and obesity lead the prevalence of type 2 diabetes mellitus continuing to increase. Also, the prevalence of impaired fasting glucose is increasing. Impaired fasting glucose is a clinical condition defined by the last ADA, American Diabetes Association, as a clinical condition characterized by a fasting plasma glucose that fits between 100 and 125 milligrams for deciliter. Recently, different studies and meta-analysis investigate the association between type 2 diabetes mellitus and thyroid cancer. This association is justified on a pathophysiological point of view by different mechanisms, and like the oxidative stress induced by the hyperglycemia, the overstimulation of the insulin-like growth factor 1 and the insulin-like growth factor 2 downstream pathway, the chronically high level of thyroid stimulating hormone, the estrogen receptor activation, and the inflammatory microenvironment. A possible role is also played by the cellular deiodinase, but this mechanism is still unclear. So the aim of our study is to evaluate the prevalence of type 2 diabetes mellitus in a population of patients with differentiated thyroid cancer for different gender and age groups. Our study also aims to evaluate the prevalence of impaired fasting glucose in this population. Our sample consists of 213 patients admitted at the Policlinic Umberto I from 2011 to 2021 for differentiated thyroid cancer excision. We did the gender stratification both on the entire population, you can see in the table, and on different groups divided by age in the sample. While the age stratification is different for patients with impaired fasting glucose and for patients with type 2 diabetes mellitus, and this was necessary to bring our sample in line with the structure of the group tested at a national level, since the expected prevalence of impaired fasting glucose and the expected prevalence of the type 2 diabetes mellitus are provided by the ESS and by the ESTAT with a different stratification by age. So, as I mentioned, we obtained the expected prevalence by the ESS and by the ESTAT, and the comparison between the expected prevalence and the observed prevalence was done by calculating the standardized incidence ratio, the SIR. And to assess if the SIR was statistically significant, we calculated the confidence interval of the observed prevalence. The data is statistically significant when the standardized incidence, when the expected prevalence of impaired fasting glucose or the expected prevalence for type 2 diabetes mellitus is lower to the confidence interval of the observed prevalence for that group. So you can see the results for type 2 diabetes mellitus, and you can see that the expected prevalence is always higher than the observed prevalence in every group, and so the standardized incidence ratio is greater than 1 in every group. The data is statistically significant in different groups of the population, and in particular for all males and all females groups, for greater than 49 years of age, all genders group, and for 50 to 74 years of age males group, and 50 to 74 years of age females group. show you the results, also the interface in glucose. And the expected prevalence here was higher than those, sorry, the observed prevalence was higher than the expected prevalence in every group. So the series greater than 1 in every group, except for inferior to 55 years of age male group. But the data, it is statistically significant only in the last group, the greater than 54 years of age female group. We have to underline the standardized incidence ratio for this group that is very high, 5.27. So our data confirm the results of an important meta-analysis previously introduced on a sample of the Italian population, and that's new knowledge thanks to the stratification by gender and age. I came to the conclusion, and I have to underline that our study gives the rationale to justify a larger cohort study on a population of diabetic patients in Italy, and this larger cohort study will eventually define the need, define these conditions as risk factors for thyroid cancer, and this larger cohort study will eventually define the need of a screening protocol in diabetic patients, and will eventually define the need of a careful evaluation of the metabolic profile by the surgeon. This was the conclusion.
Okay, thank you very much, Eugenio. Congratulations for your presentation. There are questions by the Commission, the Professor Gian Gaspar, please.
We started from a cohort of patients with differentiated thyroid cancer, and the prevalence of the histological subtype of the thyroid cancer exactly respected the one of the general population.
Okay, the Professor Consorti, could you consider yourself satisfied by the work of the candidates? Okay. Supervisor answer yes. So thank you very much. Thank you very much. So it's the time of the next candidate, who is Guillermo Fusetto de Veronesi. Before giving the words to your supervisor, Guillermo, let me make some very simple but very important special thanks. Because first of all, I have to make a special thank to all the administrative staff of the faculty of pharmacy and medicine for having organized this. The final exam of thesis, particularly to Domenico della Peruta, who is organizing this meeting, even also with the methodology at distance online. I have to thank very much the Dr. Fellow of my department and all the medical students of in degree of medicine. So the medical students, please raise your hands. Where are medical students? Okay, no, medical students who are organized this committee, they are not here anymore. Okay, thank you very much. They were in any case, and I have to make many thanks to you, the students, because you helped a lot during the last 2 years in organizing also the online lecture. So thank you very much, and your help was absolutely fantastic. And particularly Guillermo was one of the students more involved in this activity. Okay, so the title of the thesis Guillermo de Fusetto de Veronesi is cardiac injury in humans with SARS-CoV-2, a pathological study of the heart. The supervisor is Professor Andrea de Frustaci. Please, the professor, if you want to introduce briefly the candidate and the thesis.
Thank you. Mr. President, though more than 130,000 Italian people died because of COVID-19 infection, no, about cardiac involvement. What kind of damage this infectious disease produces? What contribution the heart provides to the progression and death of this kind of patient? And this is because limited study in terms of postmortem as well as endomyocardial biopsy studies are up to now provided. The presentation regards a description on the whole part of patient COVID-19 infection. The diet because of heart failure or malignant ventricular arrhythmias. Molecular studies have been done in several patients died for that, and this information are precious to interpret correctly the manifestation of patients with cardiac manifestation and COVID-19 infection, and which treatment can be provided whenever severe complications, cardiac complications appear. The candidates, Guillermo Fusetto Cronesis, contributed to this work with his great interest in following the investigations done in this category of patients, and also in providing the clinical data from that people. Please.
Thank you, Professor Fustaci. I also thank Yuri for his kind introduction. And I'd like to present this work entitled Cardiac Injury in Humans with SARS-CoV-2, a pathological study of the heart. I know you're probably overwhelmed with information regarding COVID, but just to situate this project, I'd like to say that now more than 175 million cases have been detected worldwide, and cardiac injury has been estimated to be present in nearly 20% of hospitalized patients. Moreover, cardiac biomarkers are linked with poor disease outcomes and increased mortality in patients with COVID-19. So even though we know that COVID-19 is primarily a respiratory disease, it's definitely not solely one. In fact, when it comes to cardiac involvement, we can see presentations such as heart failure in the setting of contractile abnormalities, arrhythmias, including ventricular arrhythmias that are malignant, pericarditis, and chest pain. However, even though many studies have indeed detected cardiac damage with cardiac MRI, for example, we still need to understand the pathophysiology behind these processes. So is this due to direct viral injury because of the presence of the virus in the cardiac tissue, or is it an immune-mediated injury in the absence of the virus? That leads us to the aims of our study, which were exactly to help and elucidate the pathophysiological mechanism involved in cardiac injury in the setting of COVID-19, and also to understand the histologic substrate involved in those patients. So is it only the myocardium and the pericardium that are involved, or are there other compartments in the heart that also contribute to the clinical presentation of those patients? In order to investigate this, we performed an autopsy study in 9 patients that were infected with COVID, with SARS-CoV-2, and that died
not only because of the pulmonary complications, but also because of cardiac. The important thing about this cohort is that the first 6 patients had cardiogenic shock, whereas the last 3, they developed ventricular arrhythmias and then sudden cardiac death. So what we did is we proceeded with cardiac autopsy, examining the heart both macroscopically and microscopically, which is where I want to focus on. For that, we also employed molecular techniques such as RT-PCR in order to try and look for viral genomes, not only of SARS-CoV-2, but also other cardiotropic viruses, usually involving processes of myocarditis, such as adenovirus, virus B19, cytomegalovirus, EBV, and among others, such as influenza virus, so on and so forth. We also employed immunohistochemistry methods to try and understand the cell lineages that are in the inflammatory infiltrates we're about to see. Just a few words on the gross anatomy. We can see that this heart, although not clear from the picture, is heavier than a normal heart. It's pale, flabby, and we can see this yellowish layer on the surface of the heart, which indicates a process of pericarditis. This was a huge finding in our cohort. Now, more importantly, now in this slide, there are 4 photos. The top 2 represent the myocardium, the bottom 2 the pericardium of those patients. We can see clearly a diffuse inflammatory infiltrate in the myocardium in photo C, with associated focal necrosis. This lymphomononuclear infiltrate was also present in the pericardium, as we can see diffusely. B is immunohistochemistry for cluster of differentiation 68, indicating the presence of macrophages within the myocardium. Those findings I just showed were diffuse in our cohort. These ones were more specific to the type of clinical presentation. So the top 2 pictures show intramural coronary vessels, and we can see the involvement by lymphomononuclear cells of these vessels, again with associated necrosis, constituting a process of necrotizing vasculitis of the coronary arteries. H is immunohistochemistry for cluster of differentiation 45 row positive cells, indicating the presence of activated lymphocytes, as we can see also in picture I. Picture I shows subepicardial ganglia. So now we're talking about nervous tissue in the heart. I and J both indicate nervous involvement. I being the subepicardial ganglion, as I said, and J his strategic conduction system. So when we put all of this together, we can understand and link this findings to the patient. Whereas the whole cohort presented with myopericarditis, necrotizing vasculitis, or the involvement of intramural vessels was seen in the patients that presented with cardiogenic shock. Whereas those that presented with arrhythmias and then sudden cardiac death had involvement of the conduction tissue, cardiac ganglion, which makes sense because that could lead to disturbances of the electrical system within the heart. It is very important to note that we did not find any viral genomes within the heart. So there was an absence of SARS-CoV-2 genomes in those samples. From these findings, we can infer a few things. First of all, cardiac involvement in the setting of COVID-19 may be indeed closely linked with fatal outcomes. So not only pulmonary involvement is linked with death, but also cardiac involvement could be a cause of it. Second of all, the involvement of the different compartments in the heart may lead to different clinical presentations. As we saw, the patients that had involvement of the pericardium, myocardium, and the coronary vessels presented with cardiogenic shock and severely reduced ejection fraction. Those that had involvement of the conduction tissue had electrical disturbances. Finally, the absence of the virus samples indicated that this is most likely an immune-mediated damage to an abnormal response to the virus rather than a direct viral damage. Now, we acknowledge that 9 patients may not be representative of all the patients with cardiac damage resulting from COVID-19. And there are probably other mechanisms of damage involved, but this goes beyond the scope of this presentation and also of this time slot. So I'm open for questions if you're interested in the topic, but this leads me to the end of my presentation. I thank you very much.
Thank you very much, Guillermo. Are there not any questions by the professor of the committee? No questions? The professor of the Frustaccio, you are the supervisor of the thesis. Do you want to make another comment? No?
The presentation is fine, and the results are very striking and have been recently published in the circulation failure as a recognition of the importance of the message.
Good. Good. Thank you very much. So congratulations to the candidate and also to the supervisor. Thank you very much. Just before the last the candidate, I made a mistake just a few minutes ago. So the students that have to make a special thank you are Giulia, Denise, and Martina. Please raise your hand. Okay, so thank you very much because they help us a lot in organizing this meeting. Thank you very much. Now it's the time of the good. So it's the time of the last the candidate, who is the last the candidate is Swan the Tuyan the Nguyen, and the supervisor of the candidate is Professor Valentino Valentini. The title of the thesis is preliminary experience with sentinel lymph node biopsy for oral squamous cell carcinoma. Please, the Professor Valentini, introduce briefly the candidate and the thesis. Thank you very much.
So the candidate has worked about sentinel lymph node biopsy. That is a variable window for also metastasis that sometimes can spare an elective indexation for early stage cancer of the
improving the results and with minor post-operative morbidity. Nevertheless, it's not so routinely used. So, Tessa, can you show us your results? Thank you.
Thank you, Professor Valentini, for your introduction. So I'm going to present today our presentation about our preliminary experience with sentinel lymph node biopsy for oral squamous cell carcinoma under the department of Professor Valentini, maxillofacial surgery and Policlinico Umberto Primo. So the first site of metastasis of oral squamous cell carcinoma goes firstly to the lymph nodes of the neck. So it's important to detect the diseases in the neck first and foremost to prevent further metastasis. So here, coming to the study of different sections of the neck. So we have 6 separate levels of the sentinel lymph nodes in the neck. So the level 1, level 2, level 3, and also level 4 are very commonly involved in oral squamous carcinoma, whereas level 5 and level 6 are a little bit less involved. So our study works with CN0 patients, meaning that these patients don't have any detectable nodal disease upon imaging or clinical examination. So traditionally, we use neck dissection to as a way to prevent further metastasis in these population of patients. Neck dissection has evolved from very invasive radical neck dissection over the years to a more selective neck dissection in which 1 or more lymph node stations are removed only. And this is the most commonly done for CN0 patients. So it's been calculated around 20% of all CN0 patients would develop occult metastasis. So if we subject all of these CN0 patients with neck dissection, it will be quite an invasive procedure with lots of post-operative morbidity. So we asked ourselves whether it's worth it to subject all of these CN0 patients with neck dissection. Is it worth it to just save this 20% of the patients? So here we come to our sentinel lymph node concept, which is the first node that is encountered in the drainage basin. It is also the node that is most likely to harbor occult metastasis. So we have the procedure. This is a diagnostic procedure, sentinel lymph node biopsy, in which we use nanocolloid radiotracer to map out lymphatic drainage of the neck, and then we locate the sentinel lymph node using lymphocytography. So I have a little bit of animation to illustrate this concept a little better. So we have the primary tumor here. We inject the radiotracer, and the radiotracer would drain from the primary tumor towards the first node, to the second one, and to the third. And of course, the first node that's encountered on the drainage of the tumor is the first one. So we call it the sentinel lymph node. It's not necessarily the closest to the primary tumor, and it's not necessarily the only one that's considered to be sentinel lymph node. There can be many nodes that are removed. So from here, we remove the node. We subject the node to immunohistochemistry to study whether there is signs of occult metastasis. If it's positive, then we carry out neck dissection. If it's negative, then we just follow up the patients. So coming into our studies, these are the selection criteria that we use to select our patients. So histological diagnosis for SCC, absence of distant metastasis, the staging of CT1, 2, and 0, as well as at least 12 months of follow-up. The material we use are two different types of radiotracer. So we use a traditional one, which is human albumin nanocolloid, as well as lymphocyte, which is a new innovative radiotracer that's available on the market. Procedure itself consists of 3 different steps. So the first step is the injection of the radiotracer with the help of local anesthesia to minimize the pain, as well as the movement of the patient during the procedure. The second stage is pre-operative lymphocytography imaging. So we acquire both dynamic images as well as static images to study the lymph drainage, as well as to distinguish between the sentinel lymph node and the other surrounding nodes. So here's a picture of a static image in which we have the bigger spot is our sentinel lymph node. So we identify upon cutaneous projection, we prepare for surgery. Coming into the last stage, we have intraoperative identification and removal of the sentinel lymph node. So we use this gamma detection probe, which is seen in this picture here, is prepared to be sterile to the operating room. This is able to detect the sentinel lymph node as the highest area of radioactivity. We remove the node, remove it away from the surgical field, as well as we confirm it with, once again, the gamma detection probe. So this is the result of our study. So we have 5 patients that underwent the procedure with human albumin nanocolloids, as well as other 3 patients that underwent the procedure with lymphocyte. So summarizing the results of our study, we have 3 patients that have floor male tumors, 3 patients with tongue tumor, and other 2 patients with mucomucosis. In total, we have 8 patients. Sentinel lymph nodes were identified in all 8. Bilateral drainage is even observed in patient 3. It was well tolerated by all patients. So there's the shine through phenomenon, which is very commonly cited in the literature, in which the tracer, instead of draining into the lymph system, it remains in the tumor, to the primary tumor itself, hence preventing the accurate detection of the sentinel lymph node, especially for tumors that are very close to the drainage. For example, the floor male tumor, as well as the tongue tumor. So this, for our study, did not affect our study at all. A total of 19 sentinel lymph nodes were removed, 2 on average. 16 over 19 were negative for occult nodal metastasis after immunohistochemistry. We have one case of possible recurrent, which is our patient 2. So our patient 2 developed a second tumor at the same site of the first tumor at the base of the tongue, even after clear margin surgery, as well as negative sentinel lymph node biopsy. And we have another patient, which is patient 8, which had having had the sentinel lymph node biopsy positive, she was further on with neck dissection after that. So despite our preliminary experience of our study, as well as a small patient scale, our results of our study is concurrent with the current literature about the benefits of sentinel lymph node biopsy. So as the table shows, we have very similar sensitivity despite being so much less invasive. We have specificity, it varies depending on the subsite, the depth of invasion, as well as shine-through phenomenon, which I mentioned before. Sentinel lymph node biopsy removes so much less nodes, but at the same time, we are able to use lesser samples to further on with the extensive studies using both H&E and immunohistochemistry. It's able to detect skip metastasis as well as abnormal drainage patterns like contralateral, bilateral drainages, whereas for neck dissection only works with only the ipsilateral level. The procedure does so much better in terms of scar characteristics, soft tissue deficit, skin texture, facial nerve function, as well as reduction in lymphedema. Does so much better in sensitivity and pain scores. Also better shoulder functions, mobility, swallowing function, as well as better transition back into normal life after the procedure, and better quality of life in general. So looking into the future, we have several challenges that we face with this, with our procedure, sentinel lymph node biopsy. First is our shine-through phenomenon, which I already explained before. So there has been an attempt to experiment with different types of radio tracers like our study, with LymphoSeq, which is a very new and innovative and more selective radio tracer that is promised to overcome this shine-through phenomenon for floor abdominal tumor and tongue tumors. Also, the second challenge that we face is that there's an importance, there's a need to stratify CN0 patients better into high risk and low risk patients, because high risk patients would probably benefit directly neck dissection, whereas low risk patients are the ideal patients for our procedure and would benefit very much from a sentinel lymph node biopsy. So the criteria that we can use to help stratify these patients are T-stage and the depth of invasions. And that was my last point for my presentation. I thank you all for my attention.
Okay, thank you very much, Nguyen. Are there congratulations for your presentation? Are there any questions by the professor of the committee? Please.
For surgery, like some scan or whatever. I didn't hear. Okay, so basically our diagnostic instruments that we use are firstly at the first time the patient comes to us. Of course, after physical examination, we usually do the imaging instruments that we do is MRI, head and neck MRI with the also we can do a CT scan, and then there's also the cases of, for example, we have a doubt whether this lymph node is positive or not. We can do also ultrasound or ultrasound guided clinical aspiration. We go on also biopsy in case there is something is not going well, or yes, and then we can also do PET. But these procedures are they can only detect lymphadenopathy, which are more than 1 centimeter. So yeah, so in the case that we suspect. Thank you.
Okay, thank you. The supervisor, the Professor Valentini, could you consider yourself satisfied by the candidate? Okay. So Nguyen, your supervisor is satisfied. Thank you very much and congratulations. So this is the time, please, just a little bit. This is the time that the evaluation of the committee, just a little bit. The evaluation of the committee should work a little bit in order to establish your score. The evaluation of the committee is made by all the professors in this room, but also by Loris Pagano. Loris Pagano is a professor who is the representative of the board of physicians of Rome, and thank to the participation of the board of the physicians of Rome. I mean, at the end of this ceremony, the EU candidate will be the physicians who are able to make the profession without the state examination. The most of you, we do the exception. Okay, so it's the time we evaluation of the committee are going to another room. So you candidates and you, I mean, relatives or the parents or something like that could stay there. I mean, please limit your mobility. In order to respect the safety of the measure. Okay, thank you. You candidates, stay over there just a second because I have to say to you something to say. Okay, welcome back. I think that we are ready to assign the score to the candidates. We will call each of you the candidates, and please come here. You have to show a little bit, saying something, very little, in such a way, because in this way you are people from home that can see you. Okay, and I will call the candidates. Each by each, one by one, okay? So, Pepoli, Eugenio, please, Eugenio. Okay. Okay, Eugenio De Pepoli, the commission has evaluated in a positive way your curriculum and also your thesis that was analyzed both for the content and also for the modalities that you present the results to the commission and to the public. The evaluation was a positive evaluation. So therefore, by authority entrusted in me by director of the Sapienza University of Rome, I declare you the doctor of medicine and surgery with the final grade of 103. Congratulations. Cristina Angelotto. Cristina De Angelotto, the commission evaluated in a positive way your curriculum and also your thesis, both for the contents of the thesis and also for the presentation of the modalities. The evaluation was positive. Therefore, by authority entrusted in me by director of Sapienza University of Rome, I declare you the doctor of medicine and surgery with the final grade of 106. Congratulations. Daria Karim.
No, però
non riesce a mettere? Non li riesce a mettere in prima. Daria, vieni un po' più vicino al professore Berardello, perché così va bene? Ok. Okay. So, Daria De Karim, the commission has evaluated your curriculum and your thesis, and the evaluation was positive. Therefore, by authority entrusted in me by director of Sapienza University of Rome, I declare you the doctor of medicine and surgery with the final grade of 109. Congratulations. Doron Teodore Scemi. Little bit closer to Professor Berardello. That's okay. Okay. So the Doron Teodoro De Scemi, the commission has evaluated in a positive way your curriculum and your thesis. The thesis was evaluated both for the contents and also for the way of the presentation. Therefore, by authority entrusted in me by director of Sapienza University of Rome, I declare you the doctor of medicine and surgery with the final grade of 110. Congratulations. Shira Ben David. These are the come.
We have an orthopedic.
Okay, Shira Ben David, the commission has evaluated in a positive way on your curriculum, and also on your thesis, and the evaluation was the positive for the contents, and also for the way of the presentation. Therefore, by authority, entrusted in me, by director of Sapienza of the University of Rome, I declare you the doctor in medicine and surgery with the final grade of 110. Congratulations. Agar Zeltzer. Agar Zeltzer, the commission has evaluated in a positive way on your curriculum and your thesis. The thesis was evaluated in a positive way both for the content, the results, and also the way that you presented the results to the commission and to the public. Therefore, by authority entrusted in me, by director of Sapienza of the University of Rome, I declare you the doctor in medicine and surgery with the final grade of 110. Azal Ozkan. Okay, the commission has evaluated your curriculum and your thesis, the contents and the results and your the presentation. The evaluation was positive. Therefore, by authority entrusted in me, by the rector of Sapienza of the University of Rome, I declare you the doctor in medicine and surgery with the final grade of 110. Congratulations. You see what? Yosina Raikal John. Yosina Raikal John. The commission has evaluated in a positive way your curriculum and your thesis that was judged on the ground of the contents, the results, and also the way of the presentation. Therefore, by authority entrusted in me by the rector of Sapienza of the University of Rome, I declare you the doctor in medicine and surgery with the final grade of 110 with honor. Congratulations. Amir Khan. Amir Khan. The commission has evaluated in a positive way your curriculum and your thesis and the results and the way to present your results to the public and to the commission. Therefore, by authority entrusted in me by director of Sapienza of the University of Rome, I declare you the doctor in medicine and surgery with the final grade of 110 with honor. Congratulations. Taha, Ziad, Ayman, Al Sayed, Abdul Wahed. Very good.
It was enough, the first name.
What?
The first name was enough.
Okay. I'm sorry. So the commission has evaluated in a positive way your curriculum and your thesis, both its content and the presentation. Therefore, by authority entrusted in me by director of Sapienza University of Rome. I declare you the doctor of medicine and surgery with the final grade of 110 with honor. Congratulations. Maggie de Memeti. Maggie de Memeti. The commission has evaluated in a positive way your curriculum and your thesis that was judged on the ground of the content and also the presentation. Therefore, by authority and trust in me, by director of Sapienza University of Rome, I declare you the doctor of medicine and surgery with the final grade of 110 with honor. Congratulations. Anna Maria Manta. Anna Maria de Manta, the commission evaluated your curriculum and your thesis that was analyzed both for the content and also for the presentation. The evaluation was positive. Therefore, by authority and trust in me, by director of Sapienza University of Rome, I declare you the doctor of medicine and surgery with the final grade of 110 with honor. Congratulations. Armando Muro. Armando de Muro, the commission evaluated your curriculum and your thesis. The thesis was analyzed for the content, the results, and also the presentation. The evaluation was positive. Therefore, by authority not entrusted in me, by director of Sapienza University of Rome, I declare you the doctor of medicine and surgery with the final grade of 110 with honor. Congratulations. Gregory Arthur Michael Horsfall. Gregory Arthur Michael Horsfall. The commission has evaluated in a positive way your curriculum and also your thesis that was evaluated for the contents, the results, and also the way that you decided to present the results to the commission and to the public. The evaluation was positive. Therefore, by authority not entrusted in me, by director of Sapienza University of Rome, I declare you the doctor in medicine and surgery with the final grade of 110 with honor. Congratulations. Suan Tui Nguyen. Suan Tui Nguyen. The commission evaluated in a positive way your curriculum and your thesis, the results, the contents of the thesis, and your presentation. The evaluation was positive. Therefore, by authority not entrusted in me, by director of Sapienza University of Rome, I declare you the doctor in medicine and surgery with the final grade of 110 with honor. Congratulations. Giulia Guerra. Okay, Giulia Guerra, the commission has evaluated in a positive way your curriculum, and also your thesis that was analyzed on the ground of the contents, and also the way that you present the results to the commission to the public. The evaluation was positive, and therefore by authority entrusted in me by the rector of Sapienza University of Rome, I declare you the doctor in medicine and surgery with the final grade of 110 with honor. Congratulations. Guilherme Fusetto de Veronesi. Guilherme de Fusetto de Veronesi, the commission evaluated your curriculum and also the contents of your thesis and also the way that you presented the results. The evaluation was very positive. Therefore, by authority entrusted in me by director of Sapienza University of Rome, I declare you the doctor in medicine and surgery with the final grade of 110 with honor. Congratulations. Valeria Salmè. Valeria de Salmè, the commission evaluated your curriculum, the contents and the results of your thesis, and also the way that you decided to use to present the results to the commission and to the public. The evaluation was very positive. Therefore, by authority entrusted in me by director of Sapienza University of Rome, I declare you the doctor in medicine and surgery with the final grade of 110 with honor. Congratulations. Marco Pistone. Marco de Pistone, the commission has evaluated your curriculum and the contents of your thesis and also the way of presentation. The evaluation was very positive. Therefore, by authority entrusted in me by director of Sapienza University of Rome, I declare you the doctor in medicine and surgery with the final grade of 110 with honor. Congratulations. Alessandro Di Maio. Alessandro De Maio, the commission has evaluated your curriculum and your thesis, that was evaluated both for the contents and also for the presentation that you gave in front of the commission to the public. The evaluation was very positive. Therefore, by authority entrusted in me by director of Sapienza University of Rome, I declare you the doctor in medicine and surgery with the final grade of 110 with honor. Congratulations. Francesco Certo. Francesco De Certo, the commission has evaluated your curriculum and also the contents and the results of your thesis and also the way to present the results to the commission and to the public. The evaluation was very positive. Therefore, by authority and entrusted in me by director of Sapienza of the University of Rome, I declare you the doctor of medicine and surgery with the final grade of 110 with honor. Congratulations. Francesco not the certo, not the receiver, not also not the diet, not the bio, not the professor, not the Berardelli, and on behalf of all of you, the graduates in medicine, not in surgery, not by the International Medical School of Sapienza, Francesco Certo, not will read the Hippocratic not the oath on behalf of you candidates, not everyone, okay? I don't know if you can come not here, not because. Okay. Please, read the Hippocratic oath of Francesco. Thank you very much.
Thank you. Thank you so much. I swear by all of the healer, the strategies, criteria, and financial, that I take to witness all the doctors, to keep according to my ability and my time. To consider and keep to me as my reference, who taught me this art, so that we humble with him and it was necessary to share my goods with him. To look upon his children and my own brothers, to teach them this art. I will prescribe regimens for the good of my patients according to my ability and my judgments, and never to harm to anyone. I will not give a little drug to anyone who asks, nor will I advise such a plan, and similarly I will not give a woman a pastor to go to abortion. But I will preserve the purity of my life and my arts, and I will not cut this sermon, even to the patient with the diseases manifest. I will lift this operation to be performed by practitioners, specialists in the art. In every house where I come, I will enter for the good of my patients, giving myself part for all the tension they were doing, and all the seduction, and especially from the patients of love, with women or with men, but they free those days. All that may come to my knowledge in the exercise of my profession, or in them comments with men, which ought not to be spread abroad, I will keep secret and I will never reveal. If I keep this oath faithfully, may I enjoy my life and practice my art, respected by all men in all times. But if I swear to remain divided, may their words be my lot. Thank you.
So doctors, so please the reminder for life, that I am the first person in your life that call you the doctors in appropriate way. So please remember that for life. On behalf of all these the professionals of this the committee, on behalf of all professionals of the International Medical School of Sapienza of the University of Rome, I wish you the good luck for life. Thank you very much and congratulations. Grazie Presidente.